I wish to welcome the Minister. I wish to welcome the members. And I wish to welcome the officials, the HOD, Dr. Kluter, the other officials, members of the public who are our guests today, and also the officials assisting us on the side. Before we proceed, let's reflect and have a silent moment. Thank you. I will request the members of the committee to introduce themselves. If we could please proceed.
Thank you, Chair. Good afternoon, officials. Good afternoon, Chair. Good afternoon, everybody. My name is Christopher Fry. I'm a member of this committee.
Good morning, Chair and everyone. My name is Rachel van Voorham.
Afternoon, Chair. Afternoon, everybody. My name is Conrad Poole, member of this committee.
Thank you, members. Also from my side, Member Poole, welcome to your first budget meeting of the Health and Wellness Department. We look forward to your contribution to this committee. If I could then ask the Minister and the HOD, could I give them the opportunity to introduce themselves and the department?
Thank you, Chair. Good afternoon. Nama French Mbombo, the political head for the health and wellness. Thank you.
Good afternoon, Chairperson. Good afternoon, members, and good afternoon, members of the public. My name is Keith Kluti. I'm the head of the Western Cape Department of Health and Wellness. I'm going to ask the other officials to all introduce themselves with their portfolios. Thank you.
Good afternoon, Chair, members. My name is Simon Kay. I am the head of corporate services, and today I'll be the CFO too.
Good afternoon, Chair and members. My name is Sadiq Karim. I'm the Chief of Operations. Thanks.
Good afternoon, Chair and members. I'm Glenn Carrick. I'm the Chief Director of Finance.
Good afternoon, members. I am Desru Mukhani, the Director for Management Accounting.
Good afternoon, Chair and members. My name is Laura Angeletti Tutue, Chief Director for Facility Infrastructure Management.
Good afternoon, Chair and members. My name is Melvin Moodley. I'm the Director of the Health Intelligence Unit.
Good afternoon, members. I'm Corin Ching, and I'm the Director of Strategy, Policy and Planning.
Thank you.
Good afternoon. I'm Doug Newman, Head of Ministry.
Good afternoon, everyone. Chair, I'm Luke Alberts, MLO to Minister Mbombo.
My apologies to Mr. Albert and Dr. Newman for interrupting you. Is there anybody else in the online that we need to get introduced? Nobody? Any apologies, Ms. Jamshed?
And Chair, through you, we received an apology from member class from the EFF.
So noted. Thank you very much. Members, officials, the purpose of this meeting is to deliberate on vote 6, health and wellness, in the schedule to the Western Cape Appropriation Bill, Bill 1 of 2024. With that, I will hand over to the Minister to give a brief overview on the budget of the department, after which the HOD will also give a brief overview. Minister, floor is yours. Thank you.
Thank you, Chair. Can I just confirmation, is it going to go through page by page so that I just only do the overview?
You can give an overview if you don't mind, Minister, and then we will later on go page by page, if it's possible.
Okay.
Thank you.
Okay. It's fine. Thank you, Chair. I hereby presenting the budget that needs to be appropriated as according to the PFMA, which is for the 2024-25 financial year, is about 30.4 billion, which is an increase of 2.21%. Chair, when we look in terms of when the department, they'll be presenting in terms of where are the cuts, where are the releases, and also what is that we're going to do with the budget. Firstly, I need to thank whoever is responsible for the allocation of the budgets, because it wouldn't have been easy. I'm talking about health sector general. Under the circumstances that the whole country has to be working on the fiscal consolidation in regard to the growth, which economic growth. So we do understand on behalf of the health sector that we will end up being impacted for what is happening throughout the country. Chair, also in the previous budget year, which is the 23-24, you might have recalled that we started with a budget where our baseline was cut. So therefore, we continued with a lower baseline, meaning whilst we talk about the increase of 2.21%, but take into consideration that the initial main appropriation that was there and compared to the adjustments towards the end of the year, you'll find that there have been some increase during the adjustment. Now, in the 24-25, you'll find that because we're used to that, help us somehow. Now, when you look at the budget, you might see some increases, but as yet, it has dropped from the original because we had appropriated in terms of the adjustment towards the end of the year. And the other thing, Chair, with the poly crisis that is happening across the world and also in the country in regard to the, especially with the geopolitical wars that are happening like in the Ukraine and so forth, this impacted on the prices, which is the medicine, the food. As you are aware that the goods and services, when it comes to the health, is where actually our budgets spending so much money. And also the budget, which is the same as the last year, it doesn't consider the inflation. And therefore, that's why when you look at it, you mustn't look too much on actually the currency, because there are a lot of other implications. As I mentioned, like the issue of the escalating medical legal costs, the issue of the blackouts that health has to absorb, which is why there are no conditional grants or any additional funding around that in regard to mitigation of the load sharing. And then also the issue, like recently, you may recall that we absorbed some of the, I think, 10 facilities from the city of Cape Town, which is now we have to add part of the responsibilities around that. So having said that, and also some of the monies that are being owed, like the road accident fund, where they owe us more than almost $1 billion out of those. So whilst we appreciate that we have got the budget, and we need to slice in terms of what we are going to do with it, but do consider that our baseline has been tempered with in regard to the last year budget cuts. and that for this year, it's not necessarily that it might be a real increase, take into consideration of the in the inflation and all other aspects. But thank you for the team for being able to do what they could be able to do in regard to what we, because we have to deliver the services and they have to slice the budget accordingly. I'll come back, Chair, when we're doing page by page. Thank you very much.
Thank you, Minister. Dr. Klute, before you proceed, I neglected to ask the members of the public to introduce themselves. If you could please introduce yourself. My apologies to you.
I'm Christina Nomdu, the Commissioner for Children in the Western Cape. Good afternoon.
Good afternoon, Chair and members. I'm Tara Hendricks, and I'm a CGM for the Western Cape Children Commissioners.
Afternoon, members. Cameron Seist here from the Commissioner for Children's Office.
Afternoon, members. My name is Olan Ndlovu, Assistant Director at the WCCC.
Good afternoon, Chair and members. I'm Tara's mom, and I'm sorry. I'm Tara's mom, and she's a child advisor in the Office of the Commissioner of the Western Cape.
Thank you very much. My apologies again for not asking you to introduce yourselves earlier. Anybody online, members of the public? No? Dr. Klute, then you are welcome to proceed. Thank you.
Thank you very much, Chairperson and members. Just to go on where the Minister left off. A year ago, we came to the Standing Committee to table a budget. As we went into that financial year, a budget that was 1.5 billion short. In the adjustment estimate, and that was mainly due to 2 or 3 factors. The first one, there was a wage agreement that was not factored into the budget at all. The second issue is there was a reduction of conditional grants, specifically the National Tertiary Service Grant. The third factor is that the equitable share formula for health was adjusted in the National Treasury, and resulting in provinces like Gauteng and Western Cape getting a smaller proportion of equitable share allocation compared to other provinces. Those 3 factors led to us coming into the financial year last year with 1.5 billion short. What we did during the financial year, and we came back to the committee to table the adjustment estimate in November. The adjustment estimate was 780 million for conditions of employment, which was 78% of the cost. In addition to that, we got 100 million from the Provincial Treasury for service pressures. So in all, we got about 800 million against being short against 1.5. So the overall picture for us in the last financial year was actually, with a bit of saving and all of that, to be 600 million short on what we spent. And that resulted in us having to work within the context of a reducing baseline. It brings us to this budget now. And the figures that we're about to table with you, and I think the Minister explained it to you, this 30,489 billion, 30.489 billion, represents a 2.5% increase on the adjusted budget. Inflation is 5.3%. So now you can understand, and I used this example yesterday. If for every 100,000 Rand that I use in this financial year, I'm going to need 105.3 million Rand for this financial year. But if I get 102.5, it means I'm short. And therefore the short, if we take it all the way to the 30 billion, is we needed to get 1.5 billion again to be able to continue to spend what we're spending this year with the reduction. We got 753 million. So in real terms, we're 807 million short. So what this budget represents is a curtailing of activities to the tune of 807 million as we enter this financial year. And in there lies a very important issue, because now we have to say, you'll see in the whole when we go page by page, that's the refrain we keep on coming back to. That this money that we get here asks us to discontinue 807 million rands worth of activity that we have funded in this financial year. That calls us into next financial year to start saying, where are we going to find these activities to reduce? We have done two things. The first one is we've tried to maintain the money we spend on staff, that we don't reduce the staff numbers below what we have currently. So to be able to keep the staff members that we have now and to pay them the salaries that they're supposed to get, it meant that we went to goods and services and put a 0% increase on goods and services. You can imagine what that means. It basically means we have to take 5.9% cut on goods and services to be able to maintain our staffing numbers. So when we come to explaining to you in each of those areas, this refrain will run through the whole budget. Our annual performance plan now has to start talking about what does that mean? Because in the goods and services lies things such as buying medicines, buying laboratory results, buying security services, buying a whole range of things that we have to pay for in terms of that. So it's in that context that we're tabling this budget for you. Implications would be that we cannot actually continue to do what we do now, because it means we do not have enough money to maintain that services. It means we have to come back and do service prioritization. It means we have to say, what do we continue to do, but what will we not be able to be continued to do? And that's the conversation that we take into this financial year. We're doing it responsibly. We're engaging all our partners. The minister will be having an engagement with all the statutory bodies next week, where we will explain to people. And obviously, we will have to walk a journey with everyone in terms of the implications of this budget as we enter from the 1st of April. We obviously would like to walk that journey with the standing committee, because that is going to be what will play itself out as we go into this financial year. It's against that backdrop that I just want to say the overarching thing is responsible governance. That's our reality. The world is a place with multiple challenges and crises coming at the health system. We feel it. We have to work with all other sectors to be able to navigate this. And this is year one of 3 years where there is a systematic, every year, reduction of what we have. So this is a reducing budget, although nominally increasing by 2%, 3%. In real terms, it's a reductionist, it's a reducing budget. It does require us as a whole system to work together to be able to continue to render the service to the best of our ability with this reducing envelope. Thank you, Chairperson.
Thank you, Dr. Klutter. I'm going to ask the members now to ask questions specifically on the overview of the Minister and the HOD. That is, in other words, before we proceed page by page, is there any specific questions at this stage in terms of the overviews given by the Minister and by the HOD that you would like to ask questions on? Member Fry?
Thank you, Chair. Thank you for those introductory remarks. To the HOD, just wanted to check, is the fact that we're not touching staff costs, that the costs will go ahead, is that taking into account the public service wage increase? Because that will be the refrain from all the departments. I mean, that was the refrain in the Department of the Premier earlier this morning. Just wanted to check if that's also the refrain. That's why you're not cutting staff costs, and that's why you have to go in goods and services and slash that by 5.9%. Just want to make sure that that's the right thing.
Either.
Thank you, Chairperson. Thank you, Member Fry. The bottom line is between November, December, and January, we were facing, with the in-year pressure, a projected over expenditure, and we had to significantly reduce the number of staff that we could take in. So we have had downward adjustment of our warm bodies in year. We got to the situation that caused us to be able to be within budget for this financial year, but it had a significant impact on our ability to render services. So it affected from primary care nursing to the most highly specialized services, resulting in the open letter that the academic heads at Grootskeer and Tygerberg wrote to the National Minister, the Finance Minister, and the province about having to curtail services. So our backdrop in this financial year, that 600 million that we were short was an adjustment of our staffing to come within that. So we're heading towards the end of March, 2 weeks' time, to be able to pay as many of our bills as we can. And we will obviously come with the annual report and talk to the committee afterwards. We enter this financial year with having made that to say we cannot, over years and years of consolidating to a bare minimum of staffing, we cannot go below that staffing because it will disrupt the service to the point that at certain places, service is at the risk of collapsing. So Member Fry, that's out. We're taking a system approach of saying, this is a budget, the money is decreasing, but we cannot go below that as staffing. So to take that on, I mean, you can imagine the finance managers in our department, because we're taking this on and saying we're visiting almost that entire shortfall on goods and services, which requires us now to do significant reduction of waste, reduction of cost, reduction of what we do to be able to meet the goods and services challenge that we've placed. But that's just the context for the decision.
Thank you, Dr. Klute. Members, Member Windvogel.
Thank you, Chairperson. Chair, allow me to welcome the input by the Minister as well as the HOD. While we understand the fiscal consolidation environment as explained by the Minister as well as the HOD, we got 800+ million, that's my understanding, last year, and an additional 2.2% this year. So for me, it can't be that we are that short in budget considering that the increase is close to 1 billion. So I would like to ask to what extent did the vandalism of the taxi industry protests of last year have an effect on our budget? Thanks, Chair.
Thanks, Doctor. Thanks, Member.
So thank you for the question from Member Windvogel. Just to reiterate, when we are saying that we have an envelope of money, the envelope of money for activities, the activities itself, the warm bodies, the inflation on being able to employ staff is 5% more every year, right? So if you don't get the 5%, you can then afford fewer staff members. So although we saw nominal increases of 2%, you run at an inflation of above 5%. And the 5% is conservative. We know that we import equipment from overseas that goes up 5 plus 4%. It goes up as 9% in certain issues. So the real issue of the finances is, unless you get inflation-related increases, you are reducing your budget. So again, I reiterate, we were 1.5 billion short. Just because we get 800 million, it means you move from 1.5 short to 700 short. We had to do additional savings of 100 million to get to 600 short. So that is our reality of last year. That is within the context of what the minister is saying, that that envelope that's reducing in the real terms. With that envelope, you have to do all kinds of things that you didn't prepare for. With that envelope, you have to accommodate rise in expenditure for fuel for generators, for repair of generators. You have to prepare for people not being able to get to work because of the taxi strike. You have to prepare and spend money on the floods that was in Overberg and cut people off. That is all the things on top of that, that you didn't get budgeted for. You have to absorb all of those into the envelope that you got. That's the context that we face. We are going into this financial year telling the committee that we are, in real terms, 800 million short, irrespective of the 2.2% increase. We are telling you that on top of that, we are likely to still have this year things that we can't predict now to spend money on, for which we're not currently spending on. And it has to be made in that context of what we have. So I hope that gives the context for the picture of the money and what the money is used for. Thank you, Chairperson.
Thank you, HOD Kluter.
Thank you, Chair. Chair, I sat and listened to the Minister and the HOD, and they both are referring to the challenges and the shortfall in the budget. But at a later stage, HOD said the lot of challenges that comes in their way, like taxi strikes and all of that, there's additional cost and load shedding. And my concern now is, without the shortfall we have, still we render the service we have to give for our people. So if Minister and HOD just can remind the House of what innovative ideas, programs, and projects they launched in this year to overcome the challenges.
Dr. Kluti.
So thank you, member. That's a very, very important question, because what we are implying is to say to you, despite all of that, we still continue to see babies at health facilities. We still continue to do immunizations. We still continue to see people in emergency centers. We still continue to see people that need operations. We still continue to do what we need to do. Ambulances still go to pick people up. The issue is, all of those cannot be at exactly the same level as it was before. So the transactional impact of what I've explained to you is where you would have waited for 4 hours for an ambulance, you might wait for 5 hours. Where you would gone to an EC and you would have waited 3 hours if you were orange, you might now wait 4 hours in the EC. But we always make that point. If you need the care, you will get the care in the system. But the system have to give. And a lot of that give is, it transfers the discomfort of the lack of resources, or the relative lack of resources. A lot of that comes and transferred onto the patient. The saddest thing for us is the poorest of the poor that must get the service feels that discomfort. So they must wait a bit longer. They must do this, they must do that. While at the same time, that poorest of the poor has less resources in terms of food, has less resources of being able to get to health facilities, has less resources for somebody else to look after a family member while they need the care. So the people that actually take the brunt of this is the poorest of the poor. And what we do is we, within our power, then make things such as, okay, are there people coming to the health facility that potentially should not be able to come to the health facility? Can we go to their homes instead of them coming into the health facility? So we start delivering medication to people. We start saying to people, actually don't come in, make that effort, take the taxi, come in. A doctor or a nurse will call you. So we do telemedicine. So that's all the things we learned in COVID, and we have accelerated a lot of that. I've just given you that as an example. I would like the minister to explain that the people from George doesn't have to come to in the EC from George all the way to Grootskeur, because now we have a robot that helps people not to travel in all of those. So it is from the small thing of delivering medicines to people's homes, going into communities without the people having to come to the health facility, all the way to the very highly expensive things, and in between multiple best practices actually that others are learning from us in terms of being innovative. Literally in our department, there's almost like an innovation every week. There's 3 or 4 new innovations. I have a meeting that I chair with senior managers in our department every 2 weeks. We are blown away when we hear what people share of what they do to make do, to cope, and to do these things. So thank you for the question. Thank you.
Thank you, Dr. Klute. Minister?
Yeah. I think again, when we end up looking at the figures, if you look at the column for the 2023-24 main appropriation, which was 28.8 billion, and then you look in terms of what we adjusted, and then we ended up having a revised estimate of 29. So when you look, so it means that in the 23-24, it ended up with a 29 billion because we did the adjustments. Now, comparing the 29.8 and the 30.4, this is what we're talking about. That so you mustn't look in terms of at the beginning of the year, we appropriated 28 and now we have 30. It's because during the course of the year, we did an appropriation that gave us a adjusted appropriation, which is at least we could be able to do ABC. And now, for example, part of it was about the additional money that was given for the wage bill for 78% of the staff members. So that's why when we do the comparison, we were saying that with the 30 billion, it didn't give us to go back to the baseline, because our baseline was dropped because of the equitability that was dropped. So we have been at this level. So when you add now the difference, if you look at the 2.2 difference, it doesn't necessarily take into consideration that the increase in terms of the prices, the inflation and so forth for what needs to happen now. Plus also take into consideration that with the increase in the population, which is we saw in the census 2022, meaning we have got more warm bodies of the patients that needs to come to us. We are supposed to raise up in terms of the resources, and also resources including HR staff. So the number of staff vis-a-vis the population, and take into consideration the inflation and the prices, it doesn't. So that's where the frustration is. But what we are saying is about no matter what, the warm bodies that were already inside, we have to protect them. We don't want a situation where if this clinic or as this was supposed to have 5, and then 2 probably retire, and then you say goodbye, yet even the 5, they were not as enough because of the population has increased. At least let's make sure we add that 2 that will have retired. Despite that, under the circumstances, probably they might need 7, but at least the 5. That's what we're trying to highlight.
Thank you, Minister. Members, any more questions on the overview? If I may just ask, and I'm not trying to be facetious, this morning in the vote on the Premier's office, reference was also made by the Premier again about the interdepartmental dispute and the fact that I think the mediation is taking place next Wednesday, I think. If that were to be successful and you were to get or a return, money returned to you, the portion that is still short for that matter, to what extent would that alter your views, not your views, but assist you to render expanded services? Sorry, it's not a trick question.
No, thank you, Chairperson. I'm very comfortable to answer that. I think I take you back to COVID. And we learned in a very important lesson in COVID in our department. I had to remind managers in our department, this is the lesson we learned. We learned how to be able to expand and contract services. It is, and I guess that's the question, that's actually what we are now saying to you, sir. We learned how to contract and expand. COVID, in a sense, forced us to contract and expand. So if the resources are with us, we can expand. If the resource is not there, we contract. So whatever the resource is, we can respond accordingly. And I guess that is the difficult part that we're trying to explain here. We're not saying that this is all the challenges, sir. We're saying the challenge is this is a contracting budget and we respond accordingly. It's got some implications, but the moment it expands, we can then also responsibly expand. So that's the other thing we've learned. We know where to expand because for us, primary healthcare and what I've just explained to you is the places to expand. Where the poorest of the poor suffers and access is a problem. If we have to expand, we can expand in those places. So that's my answer, sir. I mean, our own estimation of the intergovernmental dispute, it's unlikely to result in us receiving additional resources. But it is a process that needs to be gone through. But we can contract responsibly. We can expand responsibly. And actually what we did, and we've said it a few times in the COVID years, if members of this committee can remember, we came here and said we returned money to Treasury that we didn't need because we did not want to use money irresponsibly. So that's, I think, is our biggest lesson. It's the biggest strength that I believe our department has. Thank you.
Thank you, Minister.
And also for us, while we are talking about health sector, but we look holistic, plus also the whole ecosystem where health is part of. Because if it so happens that one particular problem could be resolved in terms of the prevention and the promotion within the space of the social development sector or in the space of the job sector, if indeed we are convinced based on the research that rather the money will need to be diverted there, because it's not about that health wants more money. It's about fighting to ensure people become healthy and those who are living with a disease, they still have in terms of being well. So the point we're trying to make, we cannot argue against on equitable budgeting because even us, we put more resources where there is a need. So we don't say, oh, which is in the metro, we don't say southern, which is the South Peninsula. Southern, stay with your money, even if, let's say, the eastern or the Khayelitsha, there's a need. Like one particular example is about where there's a need in Khayelitsha. Therefore, Northern and Tygerberg, can you please give to, or Mitchell's Plain or Clefontaine, can you please give to? Because you have to look at the whole health system. So similar, the whole health system is not only in the Western Cape, it's for the whole country. So we're not saying, whilst we understand the rationale behind that equitable share, dropped. We understand because under the circumstances where the country is in debt and also there have been floods and everything elsewhere. Therefore, one could understand when they have to rob Paul and pay Pauline. But what we are arguing is about it must be fair and also take into consideration there are also like the increase in the population, the issue of the interpersonal violence that we have in the Western Cape compared to those things needs to be taken into consideration. So based on your question, the issue, for example, of the road accident fund, that one, we want our money. We want our money. That's our money. That there's no anything about it in regard to terms of it's our money because we've already rendered the service. But in regard to if with the intergovernmental dispute, if that 1 billion could come back, we'll want to have a slice as well. But if it so happens that that slice will far much be better be used in one other aspect, as long that it will benefit towards the healthy population. So we don't want a situation is about we want all our money. Actually, we've done that in the past. That we are part of the safety, we are part of the mental well-being, we are part of the whole of these social issues. And also, even we are going towards One Health. One Health is one of it where we don't only look at the health of the persons, the people, we also look at the health of the animals, or health of the plants. That we even go to the root of the Human Development Index, where we want to issue, we drive the issues of equality in regards to the issues related to education, to the gender equality and all of those, because if those things are resolved, it will impact on us. So it's about the ecosystem. And we assist where we find that there's a weakest link, even if it's outside our sector. If it so happens that it will impact on us, we're the first one to jump. So under the circumstances, what we're saying that there is some elements of unfairness. Unfairness is regard to when I could be able to say, give that money to social development, for suppose I'm acting in social development, let me say, so that's why I'm making an example. It's not necessarily that I'm targeting, I'm targeting because it's targeting me as well. So that's why we could be able to say, give that money for the social development to provide food for children to prevent malnutrition. We're fine with that. But other sectors should be able to say, give that money to health. Because like now, what we are presenting. So we haven't been in a position where it says, give that money to health. That's what we're asking. If we could be able to do others, so why other sectors cannot see our pain? That the issue is going to be deliver things that is what we're supposed to deliver, but there are many other things. But for me, it's the whole issue of the moral injury of our staff, because there are no health services without staff. Because when we say we protect our staff, it doesn't mean we're adding posts. It means that where they're supposed to be 7, it's still going to remain 5, and yet the population is increasing. We'll have a staff burnout around that. So that's why we're appealing to all other sectors. Please help us. In return, we always do help you, or we will help you, or we're all going to benefit with a healthy population. That's what we're saying.
Thank you, Dr. Kluti. Thank you, Minister. Comes back to this, ne? Sorry. Before we table the budget, we've been joined by one more member of the public and one more member. If they would like to introduce themselves for the record, please. Member Barker Vos. If you wish to introduce yourself, please. Thank you, Member Barker. That's fine.
My name is Ndombizane Leclerc and my surname is Baku Force. Thank you, Chair.
Thank you, Member.
I greet everyone in the house.
Thank you. And another familiar face?
Morris Kiewitz, UWC.
Good afternoon and welcome. Members, we will now proceed to table the budget page by page. The Just for everybody's notification, this vote or the budget then starts on page 223 and ends on page 264. Pages 265 to 297 are annexures, and obviously members can also ask questions about that if they want to. I therefore table this budget, and I will now allow members of the public, members of the House, and then members of the public to make submissions on the budget and ask questions to which the department and or the minister will then respond. Members, are there questions that you would like to put? Member Baku Vos. 1 minute. Member Baku Vos, before you proceed, I understand there's a member of the public online as well. Would the member of the public online please like to introduce him or herself? I can't see, the picture is blocked. There we go.
Hi, my name is Laurie Lake. I'm from the Children's Institute at the University of Cape Town, and very delighted to be here and to be raising a flag for children in the midst of these austerity cuts.
Thank you so much, and thank you for joining us, Ms. Lake. Member Baku Vos, you had a question? Member Windvogel after her? Member Fry? Could you just put on your mic, please, Member Vos? It is on. Can you turn it?
Yeah.
Thank you.
On the page 226, the last paragraph in the last sentence, I have a question there. Given this realization, and why then is the department opposed to the NHI, as it is one of the best mechanisms to address health inequalities and ensure universal health coverage? That's my first question, Chairperson. And the second question is on 228, the second last paragraph, which is I would like to know what are the key decisions that were taken on this engagement. Are there any projects that are likely to be phased out? And if so, which ones and which facilities are likely to be affected? That's my second question. Page 228, the second last paragraph. Yes. And the last question is on page 232, table 7.1. It is worth nothing but both the equitable share and conditional grants allocation have been increased by over 1 billion. However, the theme of department in this budget has been insufficient budget allocation and decreasing budget. This is also linked to the public announcement made by the HOD that we may witness increased service pressure due to budget cuts from national government. Can we get more clarity on this? What will the increased allocation cover and where are the shortfalls? That's my last question. As usual, the last one now. We have
Member Baku Vos, I should have introduced the opportunity to members to ask questions by saying that let's limit it to 3 questions for the first round, if you don't mind, and then we'll do a...
Okay, thank you, Chairperson.
In fairness to all. Thank you very much.
Thank you.
Dr. Minister, would you like to respond now or take more questions first? More questions? You would wish to respond, please. Thank you.
Thank you, Chairperson. Thank you, Member Baku Vos. I just want to locate on page 226, when you say in the last paragraph, which talks about whole of society approach, working with stakeholders, One Health, working with public policy, you are posing a question to us, why in light of that paragraph, the department don't support provisions in the NHI Act. I just want to clarify that that's the question. Because none of those factors are actually in the Act. I just want to clarify. I'm not being facetious. I just want to clarify. Okay. So to be very clear, the department has submitted via the Western Cape Government Cabinet specific responses to the NHI Act. Our responses was related to the matters around the powers and functions of provinces compared to the national department. So it's a very specific issue. So the NHI Act speaks to certain powers get taken away from the province and it gets placed with the national. So that's one of our big responses that we had, because we believe we have a functioning provincial healthcare system that connects all the parts to the healthcare system. So our response is we would like the powers that we have as a provincial healthcare system to remain intact, to be able to render universal health coverage. So that's the one big issue that we report on in response to that. There are other issues that we've mentioned in our response, but the main one is about the powers of the province compared to, and the Act actually speaks about centralizing things like central hospitals, where it basically then says Grootskei and Tygerberg can be disconnected from the Western Cape system, and it will directly be reporting to the national department. So it could be that if the Act comes in with all the stipulations, that Grootskei and Tygerberg gets completely detached from us as the provincial department. It reports to somebody in Pretoria, and they stand loose from the rest of the healthcare system. So just to be very clear, Member Baku Vos, our specific comments in relation to stipulations in the Act is on specific matters. There's a range of other things, but that's the main comment that we came back. So the second issue is universal health coverage is something that our entire system is based on the principle of universal health coverage. So in this province, we support universal health coverage unequivocally. In fact, the pilots for the NHI pilots and the CUPs, the one that's done the most progress in the country is the one in Garden Route. Our national colleagues are the ones that's selling to us that they're learning the most from the Western Cape's approach. So for me, we are working with our national colleagues. We have registered these matters and our national colleagues are completely aware of our position in relation to that. So that is the official departmental position in relation to the NHI Act, but also in relation to the principle of universal health coverage, which we completely subscribe to. So I hope that answers the first question. The second question on page 228, and on page 228, it refers specifically in the second last paragraph on a strategic budget engagement that we had on the 31st of August. And just to explain to you what happened in that budget engagement, we had managers from across our entire department, and we said, we're facing an in-year challenge, as I explained at the beginning, of a 1.5 short, and we don't know what's going to happen in year. Subsequently, things came in, but it's likely to carry through into the outer years as we're sitting here with you. In that framework, in that discussion that day, we adopted two big important principles. The first one is prioritization has to be done in a consultative manner. So we are saying that we need to have an ethical framework of how we make decisions of what to prioritize if the money is not there to continue to do exactly what we're doing. So it is an ethical framework. Dr. Karim and his colleagues have now worked on that framework, and that framework is based on international best practice of how to consult and make difficult decisions. Transparent, involving people, and consulting around that specific one. The second big issue that we agreed in that workshop was this issue of working collaboratively with others. So it's a framework where we agreed, like Minister said, we are open to have collaborative relationships with other sectors, with other players, and we work in the best interests of people. So those are the two key decisions. So there was a decision that the third thing that actually came out of the workshop was probably that there are some small, immediate, quick wins where we could get efficiencies. So we can make some decisions about, let's call it, using our finances more prudently. That has subsequently now resulted in a series of internal policy proposals of how we should look at, what blood tests do we do for this, what medication do we do for that, and all of that. So there's a range of things that all stemmed out of this reprioritization workshop. Then the last question, if I understood it correctly, but I might defer to Mr. Kane, on page 232, in terms of these budgets here. So just first want to explain, equitable share grows with 7.2%, right? And the conditional grants grows with 5.7%. That is on the original.
Provincial funding is reduced. So if you look at the provincial finance reserve, have been buffering us against that.
Yeah. But I mean, the point is that this is not against the adjusted estimate. So when we say the final adjusted money, this that you're seeing here is not against the final adjusted money. So these amounts that looks like big increases is not against what we actually had in the budget. And therefore, what we are saying with all of these figures, it is the real increases are not 7.2 and 5.7. The real increases is not that big amount that's there. It is as explained when we started the conversation, which is, like I said at the beginning, the increases are less than what inflation allows for. Therefore, it's back to exactly the same thing. It is smaller than what we need to continue to run the services, and therefore we need to reprioritize. Thank you, Chairperson.
Thank you, Dr. Minister.
The last one, on the 232, just to make an example, in the equitable share for 2022-23, if you look in terms of the audited one, it was about 20.6 billion. And then in 2023-24, the equitable share, when we started, it was 20. It was 20. So can you see that what was audited when we close in the 2022-23, now beginning 2023, it was dropped. Whilst it was dropped, we cried tears and so forth, and then revised, and then became a 21 in terms of when we ended. Now, beginning now, for now, when you see that 2022, you cannot just compare it with the 20 in the beginning, because if you look at 2022, how we closed in 2022, and now how we close in 2023. So it's like saying, normal French, there is your pocket money, 20 rand for the year. I'm giving you at the beginning of the year for the pocket money, 20 rand. And then based on whatever, and then I say, it is not enough, the pocket money for 20 rand. And then round about October, November, I'm being given an extra 10 rand. And then I have 30 rand. So meaning now my budget now is 30 rand. Beginning the following year, I'm being given 22 rand. And then you'll say, but it's more than the 20 rand I gave you. But I'll argue that already now the budget is 30 rand. So just because you give me extra 2 rand from the beginning, so it doesn't mean that there's been an increase, because I've adjusted and then the needs now equal to 30. What is expected is about actually you increase the 30 by a certain percentage, maybe I get 32 rand. But now you take me back to when you were giving me 20 rand. That's what we're trying to highlight here. Thanks.
Thank you, Minister.
Oh, sorry, it's similar even on the conditional grants, because if you look at the 2022-23 for the conditional grants, it was 7.4. And then when we started 23-24, it was 7.1, which is, I mean, in terms of the main appropriation, and then it dropped. So that 7.4 of this year, you may argue and say that is 5.7 increase. But if you look in terms of where we're coming from, it's still the same kind of the analogy that I'm making in regard to that.
Thank you, Minister. Member Windvogel.
Baie dankie, Chairperson. Voorsitter, ek wil saamstem met die HOD en die minister toe hulle iewers in hulle antwoorde genoem het dat daar kan nie gesondheidsdienste gegee word as daar nie gemotiveerde staf of personeel is nie. So ek stem 100% daarmee saam. En dis hoekom my question on page 227 on the first paragraph. There's mention of the management efficiency and alignment project and the macro design process, which were used to enhance systems efficiencies and to achieve operational coherence in terms of reporting line and budget consolidation and team cohesions. In this year budget, in this year's budget, we are told that the department will reduce staff numbers over the 2024 MTEF from 34,629 in the 2024 and 25th book year to 33,389 in the 26th and 27th book year. Is this cutting down of staff complement a result of the MIP and MDP process, and what are the reasons for it? What will be the impact of cutting down staff while the service pressure are getting out of hand in our health facilities? And what mitigation measures are in place? Then, Chair, can we get a breakdown of these numbers in terms of occupation? We want to know how many posts for doctors, nurses will be cut over the stated period. Then, Chair, lastly, since the beginning of the sixth administration, the department has been complaining about insufficient budget from national, province, but the department has been complaining since I started in the sixth administration. So it doesn't matter how much they will get from national, from province. For me, it now seems this is an easy excuse for the province or for the department to hide its shortcomings. But while we are currently contracting other services, the department somehow finds money to increase the budget for new programs like the violence prevention unit. So can we get an explanation about this? Where does this budget come from while the staff numbers will be reduced over the MTEF? Thanks, Chair.
Thank you, Member Windvogel. Before we proceed, we've been joined by two more members. If they would like to introduce themselves for the record, please.
Good afternoon, everyone. My name is Pat Lecker. I'm an alternate to this committee.
Good afternoon, everyone. My name is Ayanda Barnes. I'm a member of this committee.
Welcome, members, and thank you. Dr. Kluti, would you like to respond to Member Windvogel's questions, or Minister, who would like to go first? Dr. Kluti then, thank you.
So maybe thank you, Minister, to Member Windvogel. Just to contextualize the first paragraph on 227. Paragraph on 227 concludes with a newly realigned organizational structure and establishment will come into effect on the 1st of April 2024. With no increase in the number of posts on the approved establishment, enabling us to stay within our fiscal envelope. Basically, the management alignment and efficiency and alignment project was about looking at all managerial posts in our department, from the HOD to all managerial administrative posts. We went through a process of realigning our establishments that there was not a growth in admin posts in our department. And we, on the 1st of April, will now adjust the, let's call it the technical reporting line of where the posts are and that in the right place. So management has not grown. That's the point of the first paragraph on 227. So our restructuring process that was signed off by the minister that went up to DPSA, we did not expand our managerial structures. In fact, we consolidated our managerial structures to enable us to prioritize staffing at service rendering institutions. So that's the point of 227. When you go to 263, in 263, there is the fill post on 23-24, which is 34,979. And that's the personnel numbers and what the cost was. You come to 22, 24, 25, it is 34,629. That is what we try to explain in our introductory comments. That during November, December, and January, we had to readjust our, let's call it our staffing complement. If you go down further at the bottom, you can then see that public service Act appointees not covered by OSD dropped from 11,325. Sorry, if you could follow me on the page, from it to 11,212. So there is a commensurate drop here of, what is that, just over 121 posts. Public service appointees still to be covered by the OSD, 42, it stays 42. Professional nurses, 13,353 to 13,219, right? So that is how many posts? That's about 40 odd posts, for a little bit less. And so you can go on medical related at the bottom, 5117 to 5066, which is about 40, 50 posts. The point we're making here is this is what we did, as I explained earlier, between October, November, December. We adjusted what we have as a post-establishment and what we can afford during those 3 months. We're going into the financial year with 34,629. That's what we will carry through. And the minister explained. That means that number will not get less. What is in the outer years is technically to adjust or to align to what the outer years currently say is the budget. So it's a complete technical exercise, just to balance the books. It's not our intention to decrease the staff by next year to 33,745, 33,89. We told you we will do everything in our power to maintain 34,629 and potentially even grow it if there is additional money. So what is under 25, 26, 26, 27 is not a real figure. It is only figure to make the books balance in terms of what is allowed and given as the preliminary allocation for those years. It's not a real figure. It is just somebody does some technical exercise and then add it up, puts it into the tables. So what we're talking about is 34,979 to 34,629, which happened in those 3 months, and the breakdown is at the bottom of each of those. It is in that we are saying that we have done everything in our power, and we have worked with something called an approved post list. An approved post list, it is what is the post that you can afford with the resources that you have. That mechanism is what National Treasury is advising other provinces to adopt. So it is, again, a best practice in this province to be able to say, this is the post we have, this is what we want to continue to do, and to maintain our services. Therefore, us, there is no such thing as compromising on staffing and services to do other things. The Violence Prevention Unit is a specific entity that out of the Premier State of the Province address, that additional resources out of the provincial fiscus was added to the Health Department. It was not the Health Department's own budget. that actually was used to establish the violence prevention unit. It's part of the safety plan. Additional money was brought in. That's over and above the money that we spend on these services. I hope that answers the questions. I tried to follow what Member Van Vogel was trying to ask, and I hope it completely answers or covers the questions asked. Thank you.
Thank you, Dr. Klute. Minister, would you like to add something?
Generally, it's also about that. In terms of when you slice the budget, you have to balance it in the sense that you cannot just probably do the HR maybe occupying 70 or whatever percentage of your total budget. Because you'll have more staff, which is with some other provinces. What Dr. Klute is indicating that why the National Treasurer is also suggesting. Because once you don't balance, we have got more staff, you won't have a Panado. What's going to happen? Who's going to give? What will this staff will be able to provide to give when there's no Panado? So you'll have to try to maintain in regard whether it's a 55%, in say whatever percentage. It is crucial. But I did make it an example in regard to what is it that we have in the envelope, and also how much we could be able to assist with. And then also lastly, the PFMA. It doesn't allow you to appoint staff just because in a certain place there is a shortage of staff when there is no money. Because there must be money, because the whole thing about the staffing is about you have to take into consideration not only the salary, but the whole package. So that's why it's crucial. And again, Chair, I still want to maintain that there will never be health services without staff. So that's why at least what we have, we need to maintain. But again, whilst we are being given, which is the South African system where we get for the MTF for the whole of the next 3 years. But normally you end up focusing on what you have because anything might happen. Actually, towards the end of the year, as you have seen, because some of those monies, some of them are appropriated towards November. It's the things that we know that is going to happen. So similar here, we're talking about what we have right now, whether there will be appropriation, meaning that we can get more money towards the end of the year when the budgets, after the medium-term budget policy statement, so that we can add more staff, we could. But now we have to talk about what we have and what we have been provided, that this is our budget. Thank you, Chair.
Thank you, Minister. Members, more questions for this first round from your side? Can I ask a question or two, please? On page 242, and then also on page 243, page 242, excuse me, let me just get there. Under the heading expenditure trends analysis, in the middle, I think it's in, the third paragraph, sub-program 2.6. The department will increase its spending on HIV/AIDS treatment by 6.84 and bringing the budget for this initiative to 1.9833700 for 24-25. Are you able, or could you share with us or unpack for us how that will be used? Easy questions. And then on page 243, right at the bottom, earmark priority allocation, violence prevention. Quite interesting to see violence prevention increases in this budget. A total of 93.824 million over the MTF will be made available. Also, if that could be unpacked, how will Department of Health and Wellness actually become involved in violence prevention initiatives? Thank you. Doctor?
Thank you very much, Chairperson. So just on page 242, in terms of the 2.6 allocation, the revised estimate, so this amounts to an increase of 127 million or 684. So the issue with the HIV/AIDS allocation, it's part of the national conditional grant allocation that comes into our system. So I have to give you the following. context for that. At the Provincial Council of AIDS and TB, we have formally adopted an enhanced, a localized trigger response for HIV and TB. That has now been incorporated into the new 5-year National Strategic Plan for HIV and TB. Part of it is that we can now pinpoint, and Dr. Moodley's unit that does the data can now pinpoint for us where exactly the challenges lies in what we're not achieving for the HIV program. So they can pinpoint to clinic level, to suburb level. And there's a thing in HIV and TB that's called the 95, 95, 95. So for HIV is you want to detect 95% of people that is HIV positive. You want to test them so that they know their status. We can see per suburb where that figure is below what it is supposed to be. So we can now target our intervention to test more people in certain areas compared to other areas. But it's the second 95 which gives us the biggest challenge. In the second 95, it is somebody that is HIV positive, that knows their status, but they remain in care. When we say they remain in care, they continue to take their medication, and it's known to us that they've not dropped out of taking care. So that issue, the remaining in care, is the one where the biggest energy and effort will go into for HIV. And we can tell you now in which neighborhood, which area, there's the biggest drop-off for people remaining in care. So that is targeted in those areas. The last one is for everybody that is remaining in care, that their viral load is suppressed, which means that they're taking their medication sufficiently. And when you take the viral load measure, it says that they have contained their own viral load in their bodies. Again, we're doing relatively well on the third one. So it's the second one. It's people remaining in care and why they're not remaining in care. So for us on that, if you combine that now with TB, where the biggest focus for TB is the first 95, which is that there's people with TB that we need to test more to find that they have TB. It's not quite the same pockets, but we want to put additional effort into TB while keeping people on TB and curing them. We're doing a little bit better, but it's finding more people with TB. If you add those two together, this increase that you see here goes partly towards that. The thing that you don't see in these books is our relationship with external funders, because this is appropriated budget. We have a relationship with the government-to-government project program, which is with the USAID. But we also have additional funding via USAID in terms of PEPFAR for this money. But we also have a relationship with the Gates Foundation. And the Gates Foundation also gives us money. There's even an undertaking now, and I spoke to the minister earlier in the week, that even through the Global Fund will be making additional resources available. So this is the one area in the budget where we can get additional resources in. So again, when we're actually going to look at our money, we actually don't want to just report on these figures. We actually want to make it visible to everyone to see that these additional resources are counted, and you can tell you what is that additional resources we put in. So we're also developing the systems to look at money outside of the voted funds to be able to broad. So I think, Member Poole, when you asked a question earlier about innovations, one of the innovations is it's also to bring money that's not voted in addition to what we do. So this is a good example that there's more money that you're seeing here that's actually going into the whole strategy. The violence prevention figures that you are referring to, it's very specific that I said to Member Windvogel that this money was made available to us from the provincial fiscus. So Treasury found it from and added it to our budget, right? That money is specifically to set up something called the Violence Prevention Unit. Now, the unit has been established in our department. It's got a director, it's got 2 or 3 deputy directors that works in the central unit. So the Violence Prevention Unit's got 2 arms to it. The first arm is to coordinate and convene and help to bring together an area-based response. The 18 prioritized areas where the biggest crime numbers are in the province has now got coordinators from health. Basically, our job there is just to bring people together and say, the numbers for violence and crime in this area is big. We use Dr. Moodley's data, and we can tell you exactly, because of people coming into our emergency centers, where are they being injured? When does it happen? And what time of the day, and we can tell, we can break it down to women, we can break it down to young men. We even have the forensic pathology data, who got stabbed, who got killed in the last week, and we can know exactly where they got stabbed and killed. So our conveners, that's in our department, their job is to bring people together from all sectors in that area. So we've prioritized firstly to work with 3 areas. So the one area that we've prioritized to work in is in Hanover Park. The other area where we are going into is to work in Delft. And we've also prioritized Swartland outside the metro as a first step. But we have conveners for all other areas where this is happening. So we're very excited about it. So the actual job is to bring people together from other sectors. We don't do the policing, but it's to bring the policing together to say, are you doing policing in the right places at the right time? To be able to pick up that there, if you are there, you're going to be able to prevent this or all of that. To bring education together, DSD, the municipalities, do you have lighting in the street? Do you have it there? We just convene. We don't do the intervention. We use our data and we convene so that people can do things better. Even member Barnes, it's all the way up even to Beaufort West. There is an area identified. So that's out of the 18 areas. So 13 in the metro, 5 in rural. In rural, it's Theewaterskloof. It is Swartland, as I mentioned. It is Mossel Bay. It is Beaufort West and Witzenberg. So those are the 5 areas outside. So 2 days from now, actually, we're having a meeting with all the sectors together with SAPS, with the City of Cape Town. I met with the City of Cape Town 2 weeks ago. They are fully committed to bring their resources to work with us in Delft as a first learning site to actually bring all the pieces together. I think the big thing that you point out in that book, violence prevention, it ultimately takes you back to inequality. That's where it is. It's about poverty and inequality and people not having opportunities. And that book that you've just pointed out to us is where this violence prevention work is taking us to. And as the minister is saying, we are purely playing a stewardship convening role. It's to bring people to the party to say, let's improve the living conditions of people. Because as a health sector, we will benefit when fewer people call the ambulance, fewer people come into the ECs, fewer people get killed and stabbed and lands up in a forensic pathology unit. Thank you, Chairperson.
Please, Minister.
Yes. So just for interest's sake, on the 18 areas, although Dr. Kloete has mentioned some of them, for example, in the Klepfontein, the metro, in the Klepfontein Mitchells Plain, there are 7 areas, which is the Guguletu, the Mitchells Plain, the Nyanga, Philippi, including Hanover Park, the Philippi, Samora Michel. And then in the northern Tygerberg, the Bishop Lake is the Delft, which is up and running, and the Kraaifontein, that's where we launched actually it. And then in the Khayelitsha Eastern, we've got the Khayelitsha, Harare, Mfuleni, and then we have got in the other non-metro. So all 18 of those with 12 of the coordinators, which is our contribution. Those coordinators are coming from us already. So we have already launched, and the one in Delft is a beautiful success one where each and every of the different sectors, police and everyone and the civil society, they play much role. Again, Chair, we could just sit and not do anything. But the evidence does show that we have got a high interpersonal violence. Which is whether it's through gangsterism or whether it's through substance abuse and drugs and all of those. So do we just sit and then not do anything instead of just putting the bandages and putting all of these things in terms of focusing only on the wounds? And yet, when people who are presenting from the safety statistics there, we find that they don't record. Some of the cases will have been reported to them because that person who will have been beaten up on the street with unknown people first thing is going to come to us in the EC, might not go to report in the police. So within 24 hours, you will have that data there. But in the police, they won't have that data. And then they ended up not putting resources in this area. Remember, where there's a high crime, it means also the staff gets affected. So that's why for us, it's also not only about the issue of the whole of society approach, but also to protect our staff. Because like, for example, one time when there was a whole outcry about a tourist that was beaten up in Nyanga and all of those, then it was about the whole, not only the Western Cape, throughout. Something must be done, something must be done. I said, do you know that we have got 4 or 5 of the health posts, facilities there in the Nyanga, the whole area. We've got people who go there every day, going to work, not necessarily they stay in that area. We've got doctors who stay in Clifton. They stay in Clifton. They have no obligation even to go and work in Nyanga, but they will be there despite that. So it shouldn't be only when, understandable in terms of the tourism, but it shouldn't be only when there is an international outcry, yet we don't protect our own staff in that area. For me, if it need be, there must be law enforcement that are surrounding all our facilities to protect the patients, plus also to protect our staff. So we mustn't wait. So that's why we took this violence prevention unit as part of the, luckily for us, we use data and also research based on the Cardiff model in Wales that actually is doable. And you'll find that now there's more interest. It was the international security where actually they were even praising us for initiating that. And we have already, with the NPOs and NGOs, where we did the presentation, and then they saw why is that important. So we're getting there. It's part of the social determinants. I know there are commercial determinants of that. So it's part of this, but instead of just, I think, remember, Van Vogel was saying, health keeps on saying, we're short of budget, you don't hear much about what you are doing. Doing a violence prevention unit is part of it. So we're not folding our arms, we're doing as much as we can. But health financing is part of the whole ecosystem of strengthening a health system. But now, because we are talking budget appropriation, it's about the money side. But as you know, luckily we've been, when we're presenting, like in Swellendam, where we brought the communities plus the staff there, and then they showcase what we do. For example, remember Van Vogel was surprised that there's a lot that is being done. I didn't know. I said there are people are doing things there, but I think probably it's because when we are here, that's why I do a lot of outreaches, because when we're here, we're focusing on what is in page, and then you'll find that we don't say much of the other thing that's happened there. So that's why we rather go to those places, like now on the 19th of March, unzipping the health pass, so that the communities themselves can say, can see, and then ask questions on the basis, because they'll be asking, why are you not doing ABC? I said that for the ABC, we only have got 0.1% budget, or we've got no budget. So yeah, we're trying our best. But sometimes when we're sitting here, it's like about we're defending, yet we're actually talking about what the colleagues are doing there. Thank you very much, Chair.
Dr. Klute, if I may just briefly return to your reference to external funding, specifically funding from the Global TB Fund. Last year, I attended the African TB Caucus in Nairobi. And one of the things that came out there was that they mentioned that they also make a contribution to South Africa. I've been trying to establish how that funding comes to South Africa. Does it go through Treasury? Does it come directly to you? How is that funding actually disseminated? If you can, I'm not sure you're the right person to answer, but I'm not saying you don't know, but if you could please respond to that. Thanks.
No, thank you very much, Chairperson. So part of Global Fund, Chairperson, is in 2003, we were a primary recipient for Global Fund. So we used our ART program in this province, was catapulted with the Global Funding. So we got a history of working with the Global Fund. In those times, the money came directly into Provincial Treasury. We created something called Program 2.10, And that's what we reported on. And members that were maybe around in that time would have remembered when we stopped 2.10. It was before you arrived. That's when the funding then stopped. But it was the mechanism for us that came directly into a budget. The current arrangement is that it's now going to the national department, and it's not added into the financial structure of the voted funds. So it is held in a separate account, and it is then held as donor funding. So it's now formally donor funding. So it will be the same as the PEPFAR money, as all the others. So we also receive it, and at the moment we are not a direct recipient. It goes directly to the national department. It then goes to some NGOs. So in this province, there's 2 NGOs that gets quite a bit of that money. There were 3 actually, but the one decided not to continue getting the money. That was TB HIV, so they stopped their funding. NACOSA gets money via that. And then also the Desmond Tutu Foundation with Professor Linda Gale Becker that does work in Klipfontein. They get money directly from the Global Fund. I met with the Global Fund people 2 weeks ago. They indicated to us that their Global Fund grant for South Africa is coming officially to an end on the 31st of March 2025. But there's a new Global Fund grant for 5 years that is now going to be considered during the course of this year that will kick in from the 1st of April 2025 for another 5 years. So I've been invited to be part of our national team to actually put that in. So as part of our additional resource strategy, we try to influence that process so that we will be direct recipients of the resources again from the 1st of April 2025. But what they've had as an undertaking is any unspent money between now and the end of March, the Western Cape has access to it. Thank you.
Thank you, Dr. Kluti. And members, the book that Dr. Kluti refers to is this book, Best Things First, by Bjorn Lomborg. He's a Danish economist, and I would think it's compulsory reading for those of you who continue into the 7th Parliament. Thank you. Member Buns, you had a question? It's still in the first round. You have a question?
Yes, Chair. Net so 2 vraag is op bladsy 235. Under new infrastructure table 8.3. Chair, I'm noting there that the Klipfontein Regional Hospital date of building and completion has been moved to 2035, which is like 31 years from now. If I can just get an indication as to what the cause of this is. And then, Chair, my second question also on page 35, under the same table, under summary of provisional infrastructure. As per the department's annual report, we have 26 facilities that are in poor and very poor condition. Is this allocation enough to address the state of this infrastructure in our hospitals? And how many of these facilities are in C1 and C2 conditions? And are they budgeted for? If one could just get an indication on that. Thank you, Chair. Both those questions are on page 235. Thank you.
Thank you, Member Buns. Member Buns, yeah, I had a quick look here on 235. I don't see this. You know what? I think it might be on. Is it not? It's not 285. Because I was actually going to get there myself as far as the
new infrastructure, Chair.
New infrastructure.
Yes. Table 8.3.
.3, it's the bottom half of page 235. And you were referring to specific locations?
I think for the annexure in terms of the specifics is from the 285.
Yes.
Because all what is not mentioned here, I think it is also core referencing
Yeah.
285 for the infra.
Because that's also in the annual performance plan on page 1110 to 139.
Answers to the, I understand you're saying that there's a delay in Klipfontein, so we'll answer that. Your first question, your second question was? Is it maintenance projects?
Summary of provincial infrastructure payments and estimates by category. And that's a table 8.3. As per the department's annual report, we have 26 facilities that are in poor and very poor condition. Is this allocation enough to address the state of poor infrastructure in our hospitals? And how many of these facilities are C1 and C2 condition, and are they budgeted for?
That's in the annual report.
That's a question.
Yeah, it's in the annual report. Okay, so no, I understand. I understand.
Yeah.
Okay. Can I go?
In your own time.
Thank you. Thank you, Member Bonds. So what the situation with Klipfontein in terms of what you saw in terms of let's call it consultant fees and then the time frame for completion. We are currently working very closely with our colleagues, both in infrastructure delivery, also in the City of Cape Town. And we had a recent meeting with the City of Cape Town. And the idea is to speed up the delivery for Klipfontein and for Belhar Regional, but specifically with the notice on Klipfontein. So I'm going to ask Dr. Anjaletti du Toit just to give you the update of where we are with Klipfontein, because if I understand your question correctly, it's about the timeframes and completion. So there is some movement and progress, and there is some commitment. So I will ask her to give you a very clear understanding of when the delivery and completion is, but we are pushing very hard. Ministers assisted us. We've made this a priority. We're pushing very hard to get the delivery time schedule to be sped up. So I'll ask Dr. Anjaletti du Toit. The second one is that the allocations we have, which is for maintenance and for maintenance, for big projects and for replacement. And the question is it sufficient to actually get rid of the backlog that is in our annual report, Laura, of our C1, C2, and C3 facilities? So I'm also going to ask Dr. Anjaletti du Toit just to give you a sense. In short, it is not enough, but we have a prioritization process, and we're obviously trying to meet that we get a basic standard across all our facilities to be at least C3, C4 to start going into that. So, Chairperson, with your permission, I'll ask Dr. Anjaletti du Toit just to add to those two. Thank you. Laura?
Thank you. Thank you very much. In relation to Klipfontein Hospital, at the moment we are busy with the COMSET report, that is COMSET design, and is ready to be delivered sometime in October 2024. After that, we have to get the approval from the National Department of Health via a process that is called peer review. And then we will be able to proceed to the stage 3, that is a more detailed design. The issue is that this is a mega project, is a 600 bed hospital, and required the reasonable time for design and for construction. So the time frame that we receive from our implementer, the Department of Infrastructure, take in consideration the reasonable time for all the process to be accepted and to be approved, and that is the indication. So the 2020, and remember, the hospital is going to be built in different phases, in 2 phases. So the first phase will be for around about 400 beds, and the rest in phase 2 will be for 600 in total. So it's unfortunately, or fortunately, it's the timing for the construction, design and construction of big mega infrastructure. In relation to the category of maintenance and the facility condition assessment, this is coming from the assessment that we do every 5 years together with the custodian that classify the facility according to the condition of suitability and maintenance, so forth. Those one that we have for C1, I think there are 1 or 2. There are both of them considered for replacement. So the C1 means that the facility cannot be purposely function. And fortunately, in this province, despite the low budget that we receive on the maintenance, we try to actually strategize and prioritize maintenance, and our facilities are in a reasonable condition. So as the HOD said, C3, C4, and of course C5 is when it's a brand new facility. So that is the current backlog. If you ask for the backlog for infrastructure, that is including the maintenance plus the capital replacement is billions of rand. But unfortunately, of course, we don't receive that amount. We receive only 1 billion rand per year. Thank you.
Thank you, Dr. Angela Di Rettoy. Thank you, Dr. Minister. Would you like to add something there? You don't have to.
Just to say that you might also have heard the National Minister of Health when he was answering the questions in the National Parliament. No,
You didn't have my attention. My apologies.
Conversations. So, okay. And I was saying that the National Health Minister also was here when he answered the questions at the NA. He visited some of these and also saw it himself, noting that, remember, this also comes from the National Treasury. So despite in terms of the delays, but it's a mega project. I'm talking about a specific one, this one, not the other two. So it's a mega project, but it is going to happen. And when it happens, noting that it will also have an impact in terms of the whole. That's why Dr. Kluti and the city and also the other colleagues in the province have to sit down and look at it, because specifically for the Klipfontein, it will impact also on the roads. It will impact on the bridge. It will impact, of course, the schools. We know that because it will be occupying that place. So it's quite a mega project that will impact on everything. But the National did make a commitment, but we'll see that. So what the National Minister has said is what the National Minister has seen and also could be able to attest to. Thanks.
Thank you, Minister, and sorry for interrupting you. Members, that brings us to the end of round one. One moment. That brings us to the end of round one of pages, as I tried to say earlier, of pages 223 to 244. We'll now enter round two of page 223 to page 244. Member Windvogel, you are very eager to ask a question. You are more than welcome.
No, thanks, Chair. Chair, I will convert my 2 questions to resolutions, but I need to ask this one. I just want to know from the department, do we have money to feed our patients, to give them a proper meal? The reason why I'm asking that, it was all over on Facebook. I have engaged Dr. Karim Shami. When I called over, sent him a message, he was up in arms. But the message is out there. The department had, there's no money for a proper meal. And when there was a response from the department, it was, there's no budget. There's no budget, but there will be meal for the patient, but there's no budget. People must consider there will not be painkillers. There's no more the specialists of the people who are specializing in these things, like Dr. Mbombo, HOD. They know what I'm talking about. Painkillers, we know they call us the government of painkillers. The message out there, there's no more painkillers. There's no more ons gebruik ons daai ointment vir seertjies. Daar's nie meer vir sweibrand nie. Dis die message out there. And there's this low moral when it comes to staff. Because when you ask, because what we did then as a board, we went in and engaged the officer of staff. And it's like an, nee, ons weet nie wat aangaan nie. Hier is die magasyne nie. It's that attitude of staff. When people ask or when they are there, no, we don't know. It's if we can get that spirit terug, even if there's not enough, because there will never be enough. At least we must treat our patients with the respect they deserve. So I need to get that answer from the department, from our senior officials. Do you have money om ons mense te voed ondenlike meal for our patients? Then, lastly, Chair, I agree 100% with the HOD when he says to address violence, we must improve people's living condition. But I want to know, are these issues raised, or are you discussing raised in the cabinet meetings where you are sitting with your colleagues, the minister, especially the minister, when she's sitting with her colleagues, social development, safety, and all those other departments? Are you raising these issues? Because it's not, you can't handle all these things alone. It needs a whole, do you call it what approach? You know what I mean. So, but we need all of us on the bus to deal with this issue. So I really need that. Thank you, Chair.
Thank you, Ms. Windvogel. Dr. Klute. Minister.
Thank you very much, Member Van Vogel. Yeah, it is the way you describe what happened in Swellendam around how the staff responded. And one of the things we did discuss in that meeting in August, and it's something that we are working with now. When you are serially underfunded, or you feel you're serially underfunded, you get to the point where the staff members feel there's no hope. And it is real. And between that period that I said to you, November, December, January, when we had to stop for a very short period of time or constrain the filling of posts, otherwise we would have been over budget. That was the last straw for many staff members. And in a sense, I don't blame staff members, because if you've worked very hard through COVID, you've worked through all of those situations, you just feel, whenever we ask for the additional person, there is not enough resources. We have named it something, and that's what Minister Mbombo said. Our staff members that goes through that is something that's called moral distress. Now, moral distress is an actual term, because the staff member actually want to do something for somebody else, but they feel that the lack of resources prohibits them from doing what's the right thing. So the specific staff member that wrote in good intention to ask, to write to SPAR and to others, guys, have you got some additional food? Can we make a donation? Can we bring it in and give something special for Christmas? That was the origin of that whole, we don't have enough for a meal situation. Dr. De Tooy came back, he answered it very clearly, that was in good intention of a doctor that said, can we get something extra for our patients for December? So the answer is, all our institutions have money to pay people's salaries, because I now got a question from the National Parliament 2 days ago. People in Swellendam says that they don't have money for salaries. There is no such thing. There's money to pay people's salaries. There's money to pay for the providers that actually render the services. There's money to do food. There's money to do what you need to do. It might not be as much as you want or need. There is enough money. So you're very right, Member Van Vogel. Our challenge is, and it is something other than the moral distress, is when people go into what we call a scarcity mindset. You kind of you get so bogged in, you can't see positivity. Therefore, the first thing that you can do, because of that negative spiral that you're in, when people ask you a legitimate question, you then say, look, don't ask me, there's no money. Go ask Minister Mbombo, go ask Dr. Kluti, because I wasn't given money, I wasn't given stuff. Now, we don't condone it, but we have empathy for our staff. And we want them to move from that issue of being in a scarcity mindset into something called an abundance mindset, where we all say, let's get some hope, let's pool our resources, let's do things together. So one of the things that we are working with now is to ask people in geographic areas to pool together. So Swellendam is not on their own. They must work with the municipalities and work with all the PHC facilities there. And they must work with their Hermanus. They must work with Otto du Plessis. They must work with Worcester. They must work with EMS. So we call that a GSA or an ecosystem. Try and bring people together that it lifts their spirits, that you can start sharing across different places. That is what we are busy with now. But it is a long, slow process to get each of our staff members into that mode of positivity. But thank you for raising it. It is something that we take very seriously. I think the second question, wherever I've heard Minister Mbombo, she has been singularly consistent on lifting the living conditions of people. But I'm sure she can respond to that. Thank you.
Minister, thank you. Thank you, Doctor.
Yeah, I think it's one of those things which, as I already mentioned, that most of what we see as health problems is actually socio-economic political problems. And health thrive is the one that I see tries mostly to actually fix some of these, yet we are not even funded for those, because if you keep quiet, it will still gonna impact. Just making an example, in the rural or remote areas, it's easier where you say that near here in Kleprand or in Nelsport, I won't be able to build a school. Children can go wherever elsewhere, or I won't be able to provide a house because you are number 600, whatever in the list. Or there's no transport. There are no public transport. There's no public transport in most of the remote areas. But even then, you still have to bring services in Niveras, Kleprand, Morsvlei, Nelsport, Maritzburg, the Caroline village, the Kruikland Bito. I'm making an example of the remote areas. So for us, we provide similar that we don't even have a policy that says no entry or full. We still have to take people, even if they'll be piling on top of each other. But again, when I made an example of the, in terms of the equitable budgeting, it's about where there's a high demand, you'll find that it's mostly the impoverished communities. And also you'll find that like there's some of the other issues is related to what we are trying to look at in terms of the Human Development Index. You'll find that it's the areas where there's a high unemployment. It's in areas where you'll find that there's a whole other social issues. It's including the overcrowding and all of those. So in health, we could be able to bring services, but the issue is about someone must close the tap elsewhere. So that's why, even if you recall, even you used to call me during the COVID that these people are overcrowded. There must be 1.5 distance. Do something. I said, I cannot now change for people who are staying in one room shack, all 20 of them now as health workers need to resolve just because there's a COVID. It's beyond my control. So that's why, because you ask, how do we do in the Woga, or whatever, all of those. So that's why, instead of us looking only in health, in this government, we have what we used to call VIPs, the very important priorities, the priorities that the Premier identify, which is in the jobs, in the safety, well-being are some of those. In all of those, for example, in the space of safety, not only we contributed through the VPU, but the two HODs, they are co-chairing and they are presenting with all other stakeholders part of it, and then they take it to us, the political heads, and then we take it in the cabinet agenda, the first agenda after reading the minutes of the previous meeting. Each minister who's the head of that has to report. We are also part of the well-being, which is shared, the person is mostly in the DSD, but they co-chair the part of the mental health within that space. When they talk about homeless, although it's not necessary, it's not our responsibility, we are there, we talk about the homeless. When they're talking about the gender-based violence or whatever, we are there. They also co-chair and we contribute and even we share with the mayors. In the space of job, although it's called a economic cluster, we are the most vocal ones. When they are presenting that you are creating or you intend to create or will be creating, it's us who say, show us where. Because we want to know that where we're putting a whole lot of money, because for them, they are the have-nots. We're putting a whole lot of money because they have nots. Therefore, how do we ensure we provide more employment in, for example, in those kind of areas? We are the most vocal ones. So in all of those areas is part of it. Now, within our own space, I'm talking at the cabinet level and government level, we have what we call COPC, community-oriented primary care. In a small clinic, the whole of that area that is a feeder for there, you'll have the faith-based, you'll have the NGOs, you have the NPOs, you have even have the business people where they are also looking in terms of the health population in that particular area. So each and every kind of the units, they've got those. And also even in the private, because people think that we are only looking at the public. We work closely with the private hospitals in regard to how we can be able to work together. If we have got challenges on mental health or whatever, something like that, we reach out and then they say you can use our space in most of those kind of things. So again, we're not working in isolation. We're strengthening the whole ecosystem. And then where there's a weakest link, we raise it to them. If they don't, these men and women, they are the ones who just go there and make it happen. So we're everywhere. And luckily for us, we have got 4 academic institutions, the 4 universities, with the academics that also help us in case we need more information, or in case we work together, like in the different kind of the areas. We all work all together. So for us, we don't see health system as like Western Cape, but we see health system include the socio-econo-political, because as they always say that public health is political. Bringing a service in a certain area, it depends political will to do it. So sometimes you get frustrated that you have to spend so much money to bring services in Canaland or in Uniondale where there is no Go George. And then the Go George only ends in those kind of the areas. It's us who make a lot of noise. Bring Go. I'm looking at you now from George, Chair. Yes, because it cannot be that you only feed that side. And then if you go to the Uniondale, for us, we have to bring Harlem and all of those. We have to bring service there. So why can't you transport people that side so that you don't have to spend so much money in terms of transport? That's why the team is also relooking some of things like the health net in regard to, is it really worthwhile to take that Antisara all the way from Maritzburg to sleep over in Beaufort West Hospital because it's going to the specialist in George, and then probably even to Grooteskier, instead of having a robot, a robotic kind of where the specialists in Grooteskier can have a conversation and help those ones in the George, and the patient care can be put on a kind of a virtual, something like that. Thank you.
Thank you, Minister. I will make a submission anywhere, anytime about Go George between Uniondale and George. Member Baku Vos, your question in the second round. You're welcome.
Thank you, Chairperson. This will be my last question. Not even last. I see you are sabotaging me now. On page 243, Chairperson, table 9.2, I would like to know, in respect of the cuts to the budget for the 3 sub-programs, and on this page as well as sub-programs 4.2 on page 249, what are the reasons for these cuts and what will be their impact on service delivery? And lastly, Chairperson, in respect of mental health illness that leads to increased service pressures in hospitals, how is this budget responding to it, and which facilities will benefit? There was again was mental.
Thank you, Member Baker-Vos. Dr. Clutie, over to you.
Listen, thank you, Member Baker-Vos. So on page 243, the 3 programs that you are talking about is community health clinics. So the change there is, which is 2.2, that there's no change. So that means there's no growth, right? That is, then there is nutrition, but nutrition is 684. If you look at the nutrition number, it is a very small number, but we will also explain why nutrition is going down. And then district hospitals is the other one that there's no movement. So on those 3, and then if you go to 249, it is TB hospitals, that is 237. And then it is general regional hospitals, which is George, Worcester, Paul, those ones where there's no movement. So all of those, clinic, regional hospital, district hospital, TB hospital, the impact that we are seeing there is this impact where we've said the budget that we have been given has to be split between staff and also goods and services. And remember, the goods and services like almost like a 0 increase in terms of that. So where you are seeing these amounts that virtually look like there's very little movement, right? It is mainly because of the budget situation where there's not nominally big increases. So it's not, it's in our estimation, it is the places where we're just having a holding pattern across these. But it's not, as the minister said earlier, that we're taking one and we say we're not other. It's still a pooled resource. And if there's a problem in one area, we will still help out in the others. It's a little bit of what I explained, but it's well and them now. You know, there is going to be just about enough money just to keep it going for what it is. But we are doing this in all of these places that I've shown you. It is invariably where the biggest amount of money is, invariably where there's not new things coming on. The only ones that actually increase here, which is community health centers, is because we're taking things over from the city of Cape Town. And that's the one that we explained earlier as well. So remember, Baku-Vos, it is just a holding pattern. It's kind of what we have. We put those amounts there and then we cope and we move during the year and adjust if need be in terms of those ones. Your question specifically with mental health is, we make a very big point in this submission that the mental health indications are going up, you know, so the pressure is going up. So where you do see there's an increase on page 249, small is the psychiatric hospitals, 1.6. But then you see a big increase in subacute, step down, and chronic medical conditions. And in a sense, we have done quite a bit of work, again, with our other partners in other departments to say, how do we mitigate in education, DSD, with culture and sport for mental health? How do we come to community health centers to mitigate against that? And then in our psychiatric hospitals, how do we actually bring additional capacity to stabilize? So it is, again, mental health itself, which has been, me and Dr. Akarim sat in a meeting with our colleagues from DCAS about 4 weeks ago. And they said to us, the biggest problem with mental health that you have as a health department is you medicalized mental health. You convinced everybody that if they have a mental health they must see a psychiatrist or they must see a psychologist. Part of our problem now is we need to actually change the mindset of saying mental well-being and mental health is part of a continuum. All of us have it. And it's okay for somebody to look out to ask you, are you feeling okay? Just because you're not feeling okay doesn't mean you necessarily need a psychologist or you need a psychiatrist or you have to be admitted into a hospital. And then a lot of it actually is people are actually lying in really, really degrading conditions in ECs because of the trouble we have of people being admitted into psychiatric hospitals. So there's a big swing that we have to do. And she was saying to us, if you call it societal well-being, we will all play a role. The moment you call it mental health, you convince us it must be a psychiatrist and we kind of stand back. So there's a big challenge for us to reframe the way we approach mental health and make it everybody's business, as Minister Mbombo would say, so that mental well-being is actually everybody. And everybody can look out for everybody else, and then kind of look at our systems to respond. Chairperson, I hope that has responded.
Thank you, Dr. Minister.
I think for us, just to add what Dr. Klute has indicated, and I promise Member Pagu Force, I will not say much because she just accused me that once I touch mental health, I don't stop talking. I think that we have the APUs, so we have got acute psychiatry units, which will be completed soon, like in Khayelitsha. We have got upcoming beds coming, work, new infrastructure. Yeah, in Khayelitsha, there at the back, there'll be an acute psychiatry unit. Esther Refier Hospital, APU, New Somerset Hospital. I think we've got, I don't know how many. We've got as many of the page
259.
259, yes. So on page 259, you saw we've got the list of the APUs that are there so that we can reduce all of this burden. Because remember, with the Act, it's about some of those patients who not necessarily have been diagnosed as mental health. What Dr. was saying, they need to be observed as part of the 72 hours. During our time when we're doing psychiatry, we're studying psychiatry, it's about once you feel like blah, 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 you call the police, they tie you and everything, and then they just put you in a psychiatry hospital. Gone are those things now, but they need to be managed as part of the 72 hour. So that is one part. And then I'm talking now in terms of health care in response to the mental health, not mental well-being. Also, we now have specialists, which is we don't have as many. You may have a medical officer who have been trained, but they do the outreaches. So gone are the days where we'll have all these specialists, they're sitting in the psychiatry specialized hospitals. So they are everywhere. Actually, even in George, they've got their unit as well for psychiatry too, for all of the feeder areas in Garden Route and Central Karoo. So now they do the outreaches. And then the other parts of mental health that used to be neglected is the adolescents, where you'll find that they end up being mixed with the adults, or they are mixed with the children. They don't fit anywhere. Now we have got even the psychiatrists who are super specialists in the adolescent field, who could be able to do the outreaches. During was it a year or two when we added additional money? Was it 30 million? 30 million, Dr. Karen? Yeah. Where we added additional money for mental health, we also made sure that for the not adult, geriatric, for the geriatric, which is for the older person's mental health, which during the COVID, it was quite ignored, especially among women. And you don't have as many specialized hospitals that deal with the older person's mental health, other than Steckland and Alexander, I think so. Even that we have to expand, and those two specialists, they even do the outreaches for that. So the money we put, it was for that. And I think we have got projects in Witzenberg and in Klepfontein, where there's a high level of older persons, like in Gugulethu and so forth, focusing on the issue of we are busy with the mapping of the mental health issue. So that is the mental health care. The mental well-being, actually, we shouldn't be pathologizing everything that has got to do with the mental aspect, because people are going through a lot. But once you keep on stigmatizing that you need a psychiatrist, you need to go to, instead of, because sometimes, like in PAL, I know that with the additional money we gave them for the mental health, they ended up having a lot of clinical psychologists. Because in some instances, it's about the matters of the mind, not necessarily the matters of the brain or the matters of the mental illness. Hence, we have that priority of mental health as part of the whole of the Western Cape government, so that we can focus on whether it's a suicide in schools, or whether it's about the youth in terms of the suicide, or whether it's about all other groupings. And then lastly, in our community health centers, even actually not only community centers, let me say primary health care, it might be once a week, or it might be once a month. There's an advanced mental health nurse who comes and visit. You can go, like the last one, recent one that I've been to, I think it was Belva South, I cannot recall. They will tell you on Wednesday, Sister so-and-so, advanced mental health is not only looking for the patients that will have been discharged in the mental health hospitals needs to be followed, but also in terms of where people, they might want to see someone just to have a conversation. I don't know, I'm depressed and all of those. So it's part of the packages, but because of the shortage, because they are specialists, so they might be going in some other days as compared to, I know in Fuleni, it's full day in some of those that are busy, CDC in Fuleni, but in others we'll find that they might go once a week and all of those. So it's part of the whole packages around that. Thank you. See, I said little bit.
Thank you, Minister. Thank you, Dr. Kluti. Members, any more questions for this second round of pages 223 to 244? Member Windvogel?
Yeah, mine is more a follow-up, Chair.
We will do a follow-up, okay, on those pages?
Yeah, it was on the APU. Yeah. We actually, I welcome these APUs. They will indeed make a difference in our facilities to alleviate the service pressure caused by mental illness in our facilities. But alone, they will not be enough. We need those step-down facilities. How many new step-down facilities will be built through this budget, or is there nothing in this budget? Thanks, Chair.
Dr. Kluti?
So thank you, Member Van Vogel. I think what the Minister is trying to explain, that the APU is designed for acute relief of pressure of people having to be in a district hospital, in the EC, or in a ward space that's not custom-made for that. So the APU brings an immediate relief of that. And as you say, it will enable the system just to separate people out, bring them into different spaces and all of them. You are 100% correct that it's not sufficient. But I think we try to explain what the sufficient should be. It should be everything, from how you actually, in a community setting, in a school, how you actually deal with mental well-being before it becomes a mental illness. And then also what we do with primary care in terms of people being able to follow up and make sure that they're fine. Step down is a very interesting concept because we've moved away from the concept of step down. And in COVID, we learned, and it's a new term, but we're using transitional care. So it actually describes what we're trying to do, because it basically says that not everybody has to be in an acute hospital and not everybody can be at home. But a transitional care facility is where you are transitioning from the acute hospital into being able to be placed back in a community setting. And one of the interesting things that Dr. Karim and his team is looking at, when we are expanding transitional care facilities, the question is, does it need to be separate for mental health, or does it have to be in the same place? So it's an interesting comment, because if you imagine we're building APUs to have separate transitional care facilities on top of that, in itself becomes then a very unsustainable exercise. So it's a very interesting point, but the need for transitional care is there. What that will look like and how it's done is what the teams are currently busy exploring. So we will keep you posted as that unfolds. Thank you very much.
Thank you, Dr. Minister. Oh, thank you. Members, if there are no more questions on pages 223 to 244, we will take a break. You're welcome to join us for some refreshments, and that includes the members of the public. And sorry, Ms. Lake, that you won't be able to join us. You'll have to go to your own kitchen. My clock and that clock are not synchronized. It's now 16:17 on mine. If I could ask you that we start at 16:35, please. It gives us just under 20 minutes, so that we can still not sleep here tonight. Go home. Thank you. majority of members. So I think we're going to start and we're going to open again. We will now handle pages 245 of the vote to page 246. As I said earlier, pages 265 and 297 are annexures. And if you do wish to ask questions about that, we'll do that. Can I get an indication by a show of hands, questions from 25264, Member Fry?
Thank you, Chair. My question is on page 248 and 249. This would be the psychiatric and rehabilitation hospitals. I see they're increasing by, sorry, let me just get my cycle now, because, you know, I'm getting old. They're going to be increasing to an increase of 19 million for the psychiatric hospitals and an increase of 36 million on the rehabilitation hospitals. Welcome the increase. Just wanted to know what will be what will that be used for? It's 1.62% and 8.53%. I know the psychiatric hospital is probably it's a decrease, but it's a net decrease. But because latching on to Mama Baka Force's question about mental health, as you know, it's one of my my trumpet calls, and how we cater for mental health, especially psychiatric health. And then table 9.4.1 on page 249, goods and services, a decrease of 2.8%, and then on page 251, sorry, a decrease of 9.43%. I spoke briefly to Dr. Kuti in the hallway. You know, I had an experience of Grootske Hospital a couple of weeks ago where someone was in hospital and I went to visit, and I tried to use the bathroom and it was in a terrible condition. The bathroom was completely vandalized. And I appreciate and I commend the staff that work under these trying conditions. But what can we do to assist? You know, I know the cut in goods and services is the last thing that we needed right now in terms of creating a world-class medical facility that Grootske used to be. But how do we create awareness for people to take ownership of Grootske and Tygerberg? Because I understand that Tygerberg is worse than Grootske. How do we? Well, that's what I hear. Okay, not true. Okay, I apologize. But you know, how do we stop those experiences from happening? Thank you.
Sorry, Dr. Klute.
Yeah, thank you very much, Chairperson. Thank you, Member Fry. I think the question about the psychiatric hospitals on 248 and about rehab hospitals, if you go to the table on 249, it says subacute, step down, and chronic medical hospitals. So the increase, the 8.5% increase, is into this conversation that we had earlier about transitional care. So it is about bringing online additional capacity in the system. I'm going to ask Dr. Karim just to quickly elaborate on that. So he will explain to you where that expansion is and what it looks like. And then obviously, as you said, the mental health is 1.6% increase, but we described it earlier, which is that it is the program 4.3 is specifically for psychiatric hospitals. And in this province, it covers 4 institutions. It's Lentegeur, it's Stikland, it is Valkenburg, and it is Alexandra. So when you look at this figure here, it only speaks to those 4 facilities. Everything else, you know, there is still mental health in the district hospitals. There's mental health in ECs and the IPUs. That's all in different places. This is specifically those 4 institutions. And it is that what we're doing with those 4 institutions, Minister Mbombo previously said we gave them some additional resources. There is pressures in those institutions, but they're part of a bigger continuum of being able to manage mental health. Just on the goods and services, I think we made the point earlier, 2.249, that you can see what happens to goods and services for Program 4 in terms of a 2.8% decrease. That's the product of us giving a 0% and sitting and making these tough choices. Really, really, these hospitals can ill afford to have the goods and services reduced, but that is what we've had to carry through, and you'll see it repeated in other places. The issue about Grootskeer and the vandalism that you've experienced, it's probably, I said to you outside, it's one of the saddest things that if you go to Tygerberg Hospital, you go to Grootskeer, you even go to Red Cross, you go to any hospital or primary care facility, that when you do put in facilities for the use of the public, it is one of the saddest things to say that those facilities get vandalized. Because as much as you repair and you put new things in, literally a couple of days later, somebody has vandalized it. And obviously you're making a call of how do we get all of our members of public that uses public health facilities, how do they appreciate it as the common good? How do they appreciate to say, actually, I'm using this facility, but this is for all of us? And how do you get that sense of pride of saying, I am here to preserve the common good? And I think it is important that we need to go into this and consult with community leaders, with the facility boards, but we cannot afford to be vandalizing or leaving facilities in a state that's very, very demeaning for somebody else to use. So it is an important consideration, and we're going to have to seriously think how to mobilize people about looking after our resources to the best of our ability. If Chairperson, if I can just ask Dr. Karim just to speak about the subacute and the transitional care expansion.
Yes, maybe just to add very briefly on that. So we've released the policy on transitional care. So as you know, during Brackengate was the facility that you might recall. And so we've taken that facility and converted that to a transitional care facility. And the funding here will allow us to expand the services provided at Brackengate and Sonstraal. Sonstraal is another area that's in Paul. So we'll be expanding those services. And obviously that's part of a transitional care policy framework, as Dr. Kloete explained. Patients transitioning from an acute facility, hopefully, obviously, through the process home. It also will allow us the funding for multidisciplinary approach, which we obviously quite pushing quite hard. So it's not just the doctors, it's not just the nurses, it's the allied health, it's the rehab, it's the care that people require. So that funding will go towards that. And just to mention also that this is also built on, don't forget, we also have transitional care that's provided by NPOs as part of our community-based services. So it's a whole policy and it's a whole direction that the department has embarked on. And we're really quite excited that we have the additional funding. So this program is then built on transitional care services provided by NPOs as part of community-based services as well. Yeah, thanks, Chair.
Thank you, Dr. Kloete, and thank you, Dr. Karim. Members, any more questions on these pages? Can I just ask a question and it's not necessarily something that is on these pages, but as far as Program 8 Health Facilities Management is concerned, we've seen now about the additional infrastructure projects that can be found on page 259 and 260, and then also there's a breakdown of the plant infrastructure spending on pages 110 and 239 of the APP, as well as on 285 and 297 of this vote. My question is maybe Doctor, maybe the Minister. Minister, I have visited 3 facilities with you twice in George, last year and again earlier this year. It's Pakelsdorp, Parkdean and Blanco clinics, where National promised And I don't want to put words in anybody's mouth, but where National, in the presence of many, many people, promised action. And what there is today at each of those facilities, there's a container and there's shade netting that's been put up, and that is it. And it is now a year later. And I was just wondering whether you're in a position to respond to that. Thank you.
So, Chairperson, I can respond to that, and I'm going to ask Dr. Angeleti Tutwe just to provide the details. Part of the challenge that we have in the infrastructure space, and many members of the committee or previous committee members have always raised this issue with us, is so we have resources in Program 8, but as I've also previously said, we have resources in other sources of funding. So this one is specifically where the resource is part of the national department. So it's not in our vote. But now it's one thing to have the resource in your vote. It's another thing to have the resource in other places outside your vote. It's then the big thing is who is responsible for doing the actual delivery, which is back to our conversation we've had with previous committees about us depending on implementing agents and the arrangements around who is the appropriate implementing agent to be able to do this. Because the money is not in our voted funds, it is in national department. The implementing agent process is also via them. And as you rightfully say, it then becomes a very complicated process for us to do project management and oversight when the money is not even with us. It's another party that is saying that they're supposed to deliver. And by remote control, we have to do contract management. So Dr. Angeleti Tutwe can give you the implication of that for these, what was termed ARV extensions under the national department, under the national grant. Laura, thank you.
No, thank you very much, and thank you for the question. These are projects that are under the grant called in-kind grant that is managed by the National Department of Health. So they set aside some money and they decide which province and which project they would like to do. So they did it in the garden route because a few years ago was the provincial nucleus for the NHI. So that is a project where they started as NHI in-kind grant. The problem, we have an agreement with them. So there is a three-party agreement between National Health and the Department of Infrastructure and us in dealing with this project. But as you rightly said, we have a very little influence on deliverable. What happened in this specific project is that the service provider was IDT, so the Independent Development Trust, was appointed as implementing by the National Department, and they didn't perform, or they are not performing. So they had to fire the entire project team, and the project got standstill. And despite all our letters and the meetings and promise, we really struggled to get the National Health attention in solving this problem. I don't know what is happening in the other province and if they have the same issue, but it's a sore point at the moment because we don't seem making any difference despite all our effort. But as I said, there is nothing we can do because implementing is the Department of National Health. The budget is coming from them, so it's not our own budget. But we try to work according to the three-party agreement. But we are struggling at the moment. Thank you for the question.
Thank you, Dr. Angeleti.
So, if I can add, at a National Health Council Technical Committee meeting, there are reports from other provinces with similar experiences. So it's not unique to the Western Cape. Yeah.
Minister?
Just to add, the background about these projects, they're supposed to be from 2012. It's part of the NHI Phase 1 pilot in all the districts, which is each province. They were piloting each province. So for us, it was Eden, which is now the Garden Route. So there are still some of them that they just completed. I think it's one in Oudtshoorn and one that probably supposed to be completed somewhere, I think in Kanaland. So it's part of the 2012, and the last time that I was there before that, the chief director at the national level, who's responsible for infrastructure, made some promise and revised the budget, because in some of like the two, the Parkdene and the Parkersdorp, they were going to add the place to put the generator and so forth. Now, when I made a follow-up, gone. So that's a kind of situation we have.
Thank you, Minister. Thank you for all the responses. Members, you have a last chance to put a question regarding pages 244 to page 264. If there are no questions, I'm going to ask whether there's anybody in the public gallery who would like to ask questions. Please proceed.
Thank you. I have two questions, please. So my first one is where exactly in verse 6 could I find services that involve children, like services? And my second question is, in the entirety of vote 6, the word child was only mentioned 10 times, but I would like to know, excluding the times where we mention Red Cross Children's Hospital, how many times is the word child actually mentioned, and for what? Like, what's the reason? Thank you.
There's another question.
I think more comment than a question. So Tara is one of our child government monitors in the Children's Commissioner's Office, and she has sort of given you an introduction of our analytical style. So our aim in the office is to teach children to hold government to account, to make budgets child-centered and child-friendly, which will go towards the realization of children's rights. And so, I mean, one of the things that I'm very happy to share, I hope I'm not out of turn, HOD, to share some of our conversation, that the Department of Health has agreed that they will support the children in their child budget analysis campaign, where they will follow the money for children's health services to their communities. And so we are looking forward to that program commencing at the end of this month. But please do answer Tara's question.
Doctor, before you respond, I missed Member Lekker also wants to ask a question. Member Lekker, please.
Thank you, Chair. My question, Chair, is on the transition of the health facilities from the city to the province. I'm raising this because, Chair, I would really like to understand in terms of the consultation with communities and various stakeholders, was that adequate? Because wherever I go, I get to hear people who have concerned. If you're looking at Ward 47 in an overpark, their facility is going to be closed and they will be using the one across Lansdowne Road in those old houses that are there opposite the police station. And it's quite a distance for senior citizens who must walk or drive from Hanover Park into that facility in Philippi. Not only there, but in other areas as well. So was there consultation, and if there's a possibility that such a process can be reversed depending on the conditions in various areas? Thank you, Chair.
Thank you, Member. Dr. Kluti. Minister, first.
Can I start with this one?
Please. Thank you.
It's because I have to answer a phone immediately after that, once Dr. Kluti is finishing off. The 9 facilities that we inherited from City of Cape Town, nothing has changed. Nothing is still the same. The only difference, actually, most of them will find that they're the clinic, the city staff that used to work for the city staff. And then when we re-advertise, and then it's the same people, but now working for the province. All 9 facilities, nothing changed. You won't even know whether it's a city, except it might be the branding. The 10th one, the Vicente Crow, is the new city clinic that was built by the city. For it, we added more packages, actually, instead of just package as the city was going to provide. So nothing, you won't even see the difference when it comes to that. It's like here, people come in parliament, whether you are sitting that side or sitting that side, they see members of the parliament. That is that. The Hanover Park has never been part of it. It has got nothing to do with any of this, with the city. Hanover Park CHC, there's nothing, there's no closing of any clinic there. We're not closing Hanover Park CHC. We are not closing Hanover Park CHC, and it's ours. It has never been the city clinic. But in issues about the future construction and whatever, it's another debate in terms of, the new replacement and so forth. But with this, it's not part of it. Just for Shotanyana, before I give it to the team, again, it talks to also, thanks for the question, it talks also about the whole ecology thing, because you might not necessarily dealing with the children per se when you are tackling, for example, teenage pregnancy through family planning. So whilst you might be probably giving the family planning to the youngsters who are not necessarily maybe children, it's part of the first 1,000 days, because you want a brighter future for the newborn and also for the children they grow older. When you provide the base antenatal care service, you are not only servicing the mother, unborn baby who is a child. So the whole thing is about, especially now when they are still young, the perinatal period, which is actually, I've got, in terms of our health outcomes, ours, perinatal mortality and everything, we're still doing far much better. The under 5, when they are coming to us, the part of the immunization is about also dealing with the children. Of course, when they are done with the immunization, they are mostly outside the health system unless they are ill. But we have community health workers who have also school health, where they go, whether into the ECDs or also to the school, also working with our partners in regard to that. For example, the school health, we've got buses that go to the school, and there's not only the dental, the eyes, but also even the packages of the primary health care. And then the issues of the VPU, Violence Prevention Unit, which is one of the transversal. Some of the cases, for example, in Kyle, which are the team through the Dr. Mutlis, when they come up with this dashboard, they found out actually there were cases of pregnant women who would come in their second trimester, even like at 2 a.m. with a history of the violence. Like, who beats a pregnant woman who's pregnant at that time? So whilst we are servicing the woman, but it's also an unborn child. But the most beautiful project is the first 1,000 days. Because once you master the first 2 years of a child's life, especially on the issues of the nutrition, the love, and also the issue related to the play, it encompasses everything, so that by the time they are out of our health system, at least they are being taken care of. Over to you, Chair. I have to answer this, otherwise I'll be fired.
Thank you, Minister. We don't want you fired, so please go.
Thank you, Chairperson. So just to come back to Member Lekker, I think the Minister made the point that the Hanover Park CHC future building has got nothing to do with the City of Cape Town transfer. So just to clarify, City of Cape Town was 9 facilities, and it was seamlessly done. When we went to visit the facilities, what was services there before, what was services after is exactly the same package. It is just that people work from one authority into another authority. Actually, what has happened, there's been quite a lot of movement in those places since it has come, because it's become part of the provincial system. And there's been a lot of sharing of new systems and things happening in those 9 facilities. The Santa Kraal, as the Minister said, is an expansion of a service. It was a building that was completed by the City of Cape Town. But we render in the new building a service that is more than what the city rented in the building before they moved into the building. So that's an expansion of a service. And then there's 2 outstanding facilities, which is in Atlantis. So there's been lots and lots of conversation and media things, but it's been that the community of Atlantis had actually asked for the city, the services to be transferred from the city to the province. And that has now been concluded, or is in the process of being concluded, because the consultation process actually is a 3-way consultation process. The first one is that there's a consultation with community structures, because that has to now kind of go a process. Like in Atlantis, we followed that very rigorously and very contested, but we got an outcome of that community participation process. Then there's a second consultation process, and that is a consultation process within the city of Cape Town, because it has to be with organized labor within the city of Cape Town, because now you're affecting the working conditions of people that are working, and you have to respect that their employees and workers have got a right to have a consulted process internally with their workers. Then there's a third consultation, which is then us as the future employer having a consultation with the city about them having a consultation with the organized labor, so that those things all are aligned in a way that nobody come and then say this one is not talking to that one and break that. So it is a complicated set of consultations, but I believe we've done it in a mature way, and I believe that it's done in the best interest of the communities of Atlantis. As I said, Hanover Park, there is a future site identified for a new building. The only site that is available is on Lansdowne Road. The site has been purchased. There has been consultation in the ward. The issue is Hanover Park is a 24-hour or 12-hour facility because of the violence. It's got an MOU. It serves people from an area much wider than the people only living in Hanover Park. So much as Delft serves people from a wide area, Elsie's River serves people from a wide area, the Noon serves people from a wide area, so does Hanover Park. So the issue is it's not only the people of Hanover Park that accesses services there. If you go after hours, there's no after-hour facility for the whole of Philippi, the whole of that area on the other side. And the consultation is not only with the ward councillor for the people in Hanover Park, it's consultation with people that are affected and have to come to the facility after hours. That's a process. The ward councillor is not agreeing with the position of the department to place that facility on a large road, like we've done with the Noon. We placed the Noon on Kubagway. That is a perfect place for a 24-hour facility to be. But the ward councillor inside Hanover Park is not happy with it. And there's a process. And if that passes by and it doesn't go past that consultation, we will be building facilities in other places. But that just to give you the absolute facts in the state on that matter. But it's not related to a City of Cape Town issue. The issue around the children's questions, which is, I think the minister went there. And part of asking whether a healthcare system is child-centered. It's about understanding how the entire system is geared towards the needs of children and their families. And I think that's the point the minister made. If we have to say to you, go to this budget book, the budget book, you already heard very complicated terms that has 8 programs. Every single program has got resources in that contributes to the well-being of children and their families. But there is no way that we can go in and say, here is the child health budget, because it's part of the whole system. And any attempts to make a budget, a dedicated budget for a specific thing, like that's the question we answered earlier. We can say to you, go to program 4, but that is psychiatric institutions. That is not what we spent on mental health. We're spending everything in the system for mental health. Now, the biggest compliment we got, I must say, with me and Dr. Karim was in the same room, was when the previous head of pediatrics at Red Cross and at UCT retired. And he said to us, that was after 30 or 40 years. And he said to us, he must commend this province for how the province has been able, from a healthcare system, to contribute to the well-being of children in this province. Insofar as that, as for a highly specialized hospital like Red Cross, fewer and fewer people have to be admitted for things that is preventable and has been kept, it's keeping children out of hospital. That was the biggest compliment. And he said to us, if you have to invest in child health, continue to invest in community-based activities in the best possible way. So, Chairperson, we agreed with the Commissioner that the child advocates will then go to clinics, to places to see where the system responds to children, not a dedicated line that speaks to children or to budgets in that way. But thank you very much, Chairperson.
Yes, I think it also if you look at the indicators that are used in the health space, I made an example of the perinatal morbidities and mortalities, the under 5, also the children, and also the adolescents, especially, which is it's an indicator that also talks to the other sectors. For example, on the issue of the injuries and the suicide and all of those, we collect that data, and also our contribution to the national system on saving babies, saving children. I used to be part of those other committees, the NAPWANA, whatever, all of those who are contributing to such of those. So it's crucial to look at those. If we could vertically program, going back to vertical programming of such, it will take us back when we started as first years, because when we started, it was about the GOBIFF, GOBIFF, that is the growth monitoring, breastfeeding, immunizations, and all of those, which is we were done with that part. But with the PMTCT, during the HIV/AIDS, when we were focusing on the nevirapine for the children, it took us back a little bit to that kind of the vertical programs. For now, a child is not a child only by him or herself. We have to look at the whole ecosystem and the environment. Thank you.
Thank you, Minister. Member Lekker.
Just a follow-up. What are the timelines for the Philippi Clinic then? For the process that, no, the Hanover Park facility being moved to that site? With the future plans, what are those timelines?
At the back, no, at the back, what page is that? Every infrastructure, whatever phase, from the 0 phase up to the last, is there at the back. I saw it, it's also part of there. So at this stage, just making an example, some of the things that have been up there, but some of these things are, they might be up there, but it was still not as yet. Just make an example, the issue of the Mbekweni, where it was a whole kind of the outcry and all of those, the similar when we had same thing with Hout Bay, in terms of where it should be, whether it should be hang back, Mizamo and whatever, all of those. Similar, like we're talking about the Kleeffontein, which is also, so everything is there at the back in regard to that space. But the point that we're trying to highlight is about, there's no closure of the clinic, but the issue is about where is part of the conversation in terms of the whereabouts and all of those. So when they want to engage, I say that it's important, but it's not as yet urgent, because it might be 2 or 3 or 4 years down the line. So yes, let's look at the back of the page. Yes.
Dr. Kluti.
So, Member Barnes, you're asking a very important question, because Member Lekker, yeah, Barnes next to you. Okay. Member Lekker, you're asking a very important question. The issue is that the consultation process in this specific issue has been done by the ward councillor in Hanover Park. So there's a consultation process. The outcome of that consultation process was via the deputy mayor to tell the minister that this process must be put on hold. That was the outcome of this consultation, because the ward councillor does not agree with the relocation of the facility from the center of Hanover Park onto lands on the road. So according to us, the process has been brought to an hold. We're not proceeding. We're not planning. Because the one consultation part, which was to say there is a building, there is a site. The site has been cleared. The site is ready and it's fenced. But the consultation within the City of Cape Town with the ward councillor has asked for a dispute on this specific matter. The minister did say, but what are you suggesting? Are you suggesting we don't proceed? So we are not proceeding in relation to that. My point that I'm making is this is the point we made to that councillor and to the City of Cape Town. It does not only serve the people of Hanover Park. And that is a broader principle which we have been able to brought into that. But our local manager has gone this way, that way, and come to a dead still because there is no meeting with the city and the local councillor. And exactly what you said, because you were saying the people in Hanover Park says they don't want to walk across because the old people don't want to go. That's exactly what the ward councillor has been talking about. And that is the process. So you've raised an important point. We've got to a point where we believe it is in the best interest of everyone that that facility is on a more accessible route, especially for people coming from outside of Hanover Park. When we wanted to have that conversation with the ward councillors of the neighbouring areas, none of them wanted to have the conversation. They all referred us back to the same ward councillor, and that is where we are.
I never knew a ward councillor had so much power. Why are you telling me now, Andy? Unbelievable. I believe that, thank you, Doctor, thank you, Minister. I believe that has a question or a hand was or is up. I still can't see it. It's blocked there. Ms. Lake, if you have a question, you may proceed.
Yes, thank you. Thank you very much. I wanted to start by saying that I'm here to represent the concerns of the broader child health community who have been concerned for some time about the impacts of austerity cuts on children's health and children's healthcare services. And that includes organisations such as the Child Health Priorities Association, the South African Paediatrics Association, as well as the ministerial committees on maternal, perinatal and child morbidity and mortality. So hugely concerned about the impacts of austerity and how that's playing out. And I wanted to remind the department as well as the broader portfolio committee that the Constitution actually sets a higher standard when it comes to children's right to healthcare. And in Section 28, children's rights to basic healthcare services aren't qualified in terms of progressive realisation, nor are they limited by available resources. And this suggests that child health services should be prioritised within the broader basket of care. And this child rights argument has been reiterated in international law by the UN Committee on the Rights of the Child, who in their concluding observations to the state party in February this year, called on the state, the South African state, to ensure that children are protected both from inflation and from austerity cuts. And in their general comment on budgeting for children's rights, stated that if regressive measures do have to be introduced, they should ensure that children are the very last to be affected. So in this context, I was very concerned to see the significant and ongoing decline in immunisation coverage for children under 1 in the Western Cape province, especially in the metropolitan areas, as illustrated on page 42 of the annual performance plan, where we're looking at between 65% and 70% coverage, which is way below national coverage of 85.5%. And this is despite the Western Cape being one of the best resourced provinces in the country. And our immunisation coverage is even further below the target of 90% needed to achieve herd immunity. And that is one of the reasons why we saw outbreaks of measles in 2023. And to me, that speaks to the extent to which child health services are already thinly stretched and not providing adequate care nor coverage. So we are worried that we may be not putting in place adequate measures to prioritise child health services in amidst the ongoing austerity cuts. We would like to know what concrete plans Western Cape Department of Health has put in place to strengthen child health services and to protect them from further cuts, and in particular, those services delivered at primary healthcare level, given that immunisation is the primary indicator for measuring young children's access to care and a really critical intervention point for other services, such as growth monitoring, which again we are concerned about in the context of rising malnutrition and food poverty. So that's the one question, is around resources allocated to routine primary healthcare service for children, and making sure that they are prioritised within that broader basket of care, so that we don't see a further decline in immunisation as we move into 2024. The second concern is reflecting concerns you yourselves have raised about mental illness, where we've seen an increase in demand for inpatient psychiatric care, including for adolescents. And those are concerns raised on page 224 and 227 of the budget vote. Already pre-COVID, we know that only 1 in 10 children with a diagnosable and treatable mental health disorder is able or was able to access care. And we also know that post-COVID, we've seen an increase in adolescent suicides in the Western Cape, which suggests that there is an escalating need for these services. So I wanted to know how much of the 5 million allocated to psychiatric or mental health services on page 237 is earmarked for child and adolescent mental health care. I also wanted to know what measures you've put in place to protect your earlier commitment to invest in the strengthening of child and adolescent mental health services in the Western Cape, including a critical shortage of child and adolescent mental health specialists who are capable of providing both the specialised care that these children need and capable of building capacity across the system. Thank you.
Thank you, Ms. Lake. Does anybody wish to respond to that? Minister?
I can start. For the questions, the aspect of the immunization, specifically in the metro, because if you could compare in the non-metro areas where actually these packages of services, we render them through even mobile clinics, where some of them, they don't go every day in a certain place, like in a certain farm, that we have metro, that where the as correctly has said, that where people can be able to have resources. Is one of the other major reasons we kept on saying that the city clinics, the issue of the provincialization, because it's the main function of a city clinic to do the child health. That is their main function. The immunization is part of their main function. So the majority of these clinics in the metro, they are run by the city. So it's that package. And then secondly, that now we're coming from, we've seen quite a lot of anti-vaxxers. I think there were others who even took the national health also to court in regard to some of those issues. We might actually see the COVID babies when they attend school for the first time, probably later, we'll find that they might not be immunized. But for us, what we do, I did make an example of the school health services that we render, including also even the wellness buses that we render. So in all our foundation here, we make sure that we render those school health services. Also, that includes the catch-up. One of the aspects that member that member, Mama Damaris Kivitz-Loves, is about the issue of the what do we call this? The program. What do we call the program?
Community MCI.
Community MCI.
Community MCI.
Yes, as part of that, of the integrated management of childhood illnesses, IMCI, yes. Once we still also do the implementation, although it might be the IMCI looking in other format. So in short, we are aware of the shortcomings in the immunization in the city because most of the services are rendered by them. And we are trying as much as we can from our side, specifically for the issue of the school health, and also in terms of the wellness buses. On the other aspect related to the budgeting, I think I did raise it earlier, where you'll find that the other budget here, where we committed about 30 million for mental health, focusing on the adolescent and also the older persons. I did mention that, for example, that we even have allocated a child and adolescent psychiatrist who deals with that. We even added more beds in Lendegier specifically for that. And those children, actually, even they are going to school. I've been there. Their school, they are going there in that aspect of it. So I've already mentioned about that. In terms of the actual monies, the department can be able to respond, but noting we would also talk about the whole ecosystem. Some other aspects of it where it might not be a live chart, like the contribution we even do to get the data retrospective in regard to the project that the forensic pathology services they've been doing with other universities, where they could be able to investigate the child death is part of the, I think is very much aware because UCT is involved in that, where we've managed to look in terms of the causes of death in small children, where some of the death would have thought that it's a caught death, only to find that actually there have been some elements of the abuse. So that's why I'm saying that it's difficult to separate and say this is a budget for children, this is a budget for whatever, but it's easier for the other aspects like the immunization. No, there are no budget cuts for such thing as immunization because it's a core function. Actually, we even extended to working with private like clinics and other community pharmaceuticals where they could be able to give these vaccines in their own, especially in the malls, like in the clinics and all of those. Although sometimes we'll find that the issue of the wastage is one that the finance people normally have to look at it. But immunization is everywhere. There's never been any cut of budget such, but instead we are trying to mobilize as much as we can because we understand that there were a lot of anti-vaxxers. There was a lot of anti-vaxxers for the vaccines for the COVID, but we do know that they ended up now getting such entry towards the against child immunization. Lastly, if you would have seen the advert for 2025 for school basic education, Western Cape Government basic education for the enrollment, they'll say for the grade R, grade 1, and then they'll put in brackets the requirement that a road to health card is compulsory so that they could be able to ensure that they immunize the children before they go to school. Thank you very much.
Thank you, Minister. Dr. Kluti.
Thank you. So I think the two issues raised by Ms. Lake, just to come back to them. So I'll go to the second one first. The investment for mental health, as the Minister previously said, has mainly been to strengthen child and adolescent mental health services at Lendegier Hospital. Professor Rene Nassen is one of the biggest benefactors of that specific service, but she's the first one to actually come to us to say, one of the biggest things you need to do for child and adolescent mental health is to strengthen child and adolescent mental health, not in the tertiary hospital, but to strengthen it at the primary care level. She is working with us in this mental health committee that me and I referred to earlier. And she's a very strong proponent of our pilot in both Witzenberg and in Guguletu area to strengthen the capability of primary care providers, teachers, nurses, social workers, sports coaches, to become conversant with picking up when an adolescent has got challenges with their mental well-being, to provide that support. So she's, as a child and adolescent psychiatrist, is in the forefront of capacitating our efforts in the pilot, which we will roll out into other areas. Just for interest sake, the big thing that they say that young people need, because we've drawn on the Evidence Advisory Committee, is a young person needs to be taught or to be enabled how to do problem solving and also how to regulate their own emotions. So for us, if that, and again, we locate it in the whole of society thing, we link it to the violence prevention, to the areas. If we scale that for all young people to support, that is where you will see the impact on suicide attempts, because we're taking it into the bigger context. And Professor Nassim was the first one to say, we have invested and maintained our investment in child and adolescent services at Lentegeur, and they are in a much better position than they've ever been to be able to be the highly specialized service for the province. The issue around the first issue, which is about the immunization coverage, is a very interesting issue, because the issue is that on pages 40, 46, 47, 48 of the APP, there's a detailed explanation of what is happening underneath the immunization coverage. The ministers touched on some of it, and there is a differential between the city and the rural districts. But what is heartening is that first dose measles, there's been an uptake recently. So there is a first dose measles uptake, which already starts saying it's the first sign towards recovery of a low immunization coverage. We share the concerns with Ms. Lake, but the conclusion that this is a neglect of child health services is not quite the right place. This is for many factors, but not a neglect of child health services. And all our colleagues, everybody takes it seriously in our department. At our recent M&E meeting, there was a specific effort to say we will go back per geographic area, figure out what this is, what the underlying causes, and we will bring all resources to bear. The unfortunate things, it seems to be that this is it's a hangover from COVID, and it's a hangover from COVID vaccine hesitancy. That seems to be the underlying thing. So it's about going back to talking to young mothers, to families, that it's important to have your child immunized. That seems to be what is the underlying issue here. But we are working with all our teams, including the City of Cape Town, to get to the bottom of it. I think just the last thing to Ms. Lake, we hear her concerns, we hear the concerns raised by the groups of people that she represents. I think, like we've answered the Children's Commissioner and our young monitor, we believe that the system is inherently geared towards the well-being of children and their families and the ecosystem that they find themselves in. So again, Commissioner Nomdo has been, and Ms. Kivich, actually both of you are here, have been part of a special consultation session that we had in December, where we're actually taking this issue of child health so seriously that we're doing it with all other sectors, including the Children's Institute and people in universities, to say, what as a society should we be doing to look after the well-being of children, not only the healthcare system. Especially if you consider that in a survey we did recently for prevalence for stunting, the staggering figure that 41% of the households we went to, there was not enough food in the last week to feed the child. So there's big things that we need to do. And it requires all of us of society to take this very, very important issue, because children should be the one thing that the whole of society is concerned about, and all of us should rally around it. So from our side, there's no lack of commitment towards our commitment to children. Thank you, Chairperson.
Thank you, Dr. Kluti. Thank you, Minister. Ms. Kivitz, when you went out, the public had the opportunity to put questions to the department. I beg you. But if that is why I'm mentioning it to you, I'm giving you the opportunity now to put your 3 questions, if you don't mind. But you had only 1.
No, I have 3. No, I have more than 3, but we will stick to the 3.
No, we need to wrap up by 6 o'clock. I'm not trying to rush anybody.
No, we will be done in a minute.
Thank you.
It's on the first page. So the main services and core functions, the omission of the governance structure of communities, and we see the failure in Hanover Park of a clinic committee.
Apologies.
Chairperson, I'm going to repeat.
Please.
Main services and core functions, governance structures, health committees are part of the governance structure of the Department of Health. The breakdown in Hanover Park is because there is no health committee. And if you look in the budget allocation, nowhere is there a budget allocation for public engagement. If you go back and look at previous budgets, there was an allocation for engagement. So it raises a serious concern that public participation, that is a core function of the province, are not made provision for, and it's omitted out of the budget. So that's on page 223. Then, Dr. Kluter spoke about the stunting. We did a similar exercise because community MCI died. And the Department of Health needs to take responsibility for the death of community MCI. Because nutrition was part of the community MCI program and you picked it up. The same with immunizations, the same with children going hungry. And it is, as he says, we've also picked it up. When the SASSA money is finished, there's no food. And the families, previously, there was nutrition services rendered and families could go for that. The schools don't even provide for every child anymore. So for me, 2024, new financial year, the department need to look at community IMCI as a real service and not part of the community-based services where the carer focuses on the adult patient and not on the children. Then my last one is the somewhere, and I can't remember where I marked it, but it is the provision of where buildings are not completed. And my question to the department is, if the contractor does not complete the building in time, are they penalized for that? Or is that an extra burden on the department? Thank you.
Thank you, Ms. Kivitz. Dr. Kluti.
Thank you very much, Ms. Kivitz. If you talk about main services and core functions, which you then on 223, I think you make an important point, but it probably would be in the structure of the convention that we've created, is to make reference to governance and governance structures, formal governance structures, to be incorporated as part of what we offer under the programs, right? So under the main services, we say this is what we render. When we talk about governance, we normally talk about program 1, And I do think it's quite an important issue that because the minister's office is in Program 1 and the administration is in office in Program 1. If we are serious about governance and we are serious about collaborative governance with community structures, it is important that we actually make that so I think that's a very good point in terms of our maturing of our governance responsibility in our department. The second issue, which is then what is the allocation? That's the reason why I'm suggesting that it should be part of Program 1. And therefore, one of the things that we have signed off as a governance reform strategy, is our stakeholder engagement strategy, where we are going out intentionally engaging people and engaging them with a view of creating collaboration. So it's about bringing people and including them. Second thing, it is about the grounding principle is one of trust, is where we are honest with people. It's to come in and say, you are connecting with us, but we can only connect if we are honest with one another. And then the third principle is one of co-creation, but for that is the principle of fairness, which we've been talking about. So you do things that's fair and everybody benefits from it. So I do think that it's quite important that under the stakeholder engagement strategy, also part of Program 1 responsibility, we are more explicit about it because it is intentional. In November last year, I don't know how many people in the room were so tired afterwards because we engaged with the universities, we engaged with civil society, we engaged with organized labor, we engaged with the private sector. It is part of an intentional one. The minister's engagement on the 19th is about intentionally engaging with statutory bodies and the members of statutory bodies. But I do believe one of our senior managers made the point that we need to come back in 2024 to look at where we are with statutory bodies and the intentional engagement and involvement of statutory bodies as part of that. In terms of the second question, community MCI, I know Ms. Kivitz raised this issue before. And I think the point Ms. Kivitz is saying is that we need to be intentional about what we offer in community-oriented primary care, because that was what I understood the last time we spoke. Community-oriented primary care, the question is, how does community-oriented primary care bring everybody together in the best interest of children and their families? And what that looks like is, how do you have an intentional expression of reaching children and their families? So as you rightfully say, whether the community MCI approach is the right one to be incorporated into COPC, that's the conversation you and I had, and that is the conversation that we must make work of. So I fully support that direction and that we must be very intentional. The issue about what the community MCI worker did or did in the pilots we did, unfortunately, the community MCI worker comes across the social determinant stuff that we just mentioned earlier. And it can become quite for a community MCI worker, because if they don't have a system of support where they go into, it becomes very difficult for them to work. But the point is well taken, and we need to incorporate that into the work. Then in terms of the last question, if a contractor defaults, there's very severe penalties actually under our oversight. I tried to explain earlier that the problem doesn't necessarily lie with whether the contractor is under our jurisdiction. It's when the contractor defaults under the jurisdiction on somebody else that we have difficulty of influencing. So Dr. Laura Ntolethu tried to explain that when it comes to us, there will be penalties because this is the way we do business. If it's through another implementing agent and another funder and another oversight entity, that's where we have difficulty in our influence over that entity that's doing it on our behalf. Thank you, Chairperson.
Thank you, Dr. Kluti. Thank you, Minister. I know this is not social development, but just on the question of nutrition and the shocking 41% statistic that you referred to, I've been very privileged to have attended many oversight visits during joint committee meetings with social development In Beaufort West, there's a gentleman by the name of Mohammed Adonis. Believe me, he has the blueprint of soup kitchens, of providing food. He has the blueprint. I promise you that. And I beg your department to speak to your colleagues at social development. You won't have to pay him a cent. Just get him to implement his plan everywhere, and nobody will go hungry. I promise you, nobody will go hungry. Thank you. Sorry to note on that note, but to end on that note, but really, it's so unnecessary that anybody goes hungry, even if it's for one day. Members, we've come to the end of this, and I'm now going to ask the Minister and the HOD to whether they have any closing remarks, and they're welcome to share those closing remarks with us. After that, they and the officials will be excused, and then it's us, me and you. Minister.
For me, it's about all is welcome on the 19th using the different sites. There's a site in the metro, I think it's Techland, and there's a site in Mossel Bay, there's a site in Beaufort West, where we will, Dr. Cloutier and I will be here in the metro, and then it gets virtual. In regard to taking the into confidence, mostly the clinic committees and the hospital boards, because you can't invite the whole community. At least you need people will be able to ask the relevant questions about their own facilities. So it's open to everyone regarding that. Having said that, thank you very much to the members and also to the department, to the team. I understand that it was really difficult to come up with this kind of the budgeting under the circumstances. But you will soldier on, as you always do. And then thanks for the questions from everyone. Members of the public, commissioner, and everyone who's there. Thank you very much.
Thank you, Minister. Dr. Cloutier.
Thank you, Chairperson. I'm not sure whether I'm going to do something that I'm not allowed to do. But yeah, so I've been the HOD since the 1st of April 2020. As COVID hit, I became the HOD. I've been in the standing committee ever since then, as a HOD, as an accounting officer, alongside the minister. So that has been 4 years. Come May, we know that there's elections. When we return, we're not sure who is going to be in the standing committee. We're not sure who's going to be the MSC. So I would be remiss to say, to not say, really as an accounting officer, I've been in these standing committee meetings before as a senior official. But for me, being here as an accounting officer, I have had the greatest respect and the greatest, sense of responsibility and accountability when presenting in the standing committee. I really just want to thank the members for holding the department accountable and for the manner in which the members does it. I also, Chairperson, thank you to you for the manner in which you then conduct the operations here. There are colleagues that has come from other provinces that says to us, they can't believe that this is how a standing committee engagement goes with officials from the health department. It is in a different place from what they've experienced from where they come from. So I really want to express that appreciation. And then to the minister, she has been the minister for almost 10 years in the Western Cape. And I've really, really appreciated the fact when we brief her for these matters, how seriously she takes it and how prepared she wants us as officials to be in terms of taking this very seriously as an accountability exercise. But also just for the minister, just to say appreciation for her being able to, in a sense, appreciate and engage us with the complexity that we face. It is a very complex terrain. It's a very complex set of moving parts. And my real appreciation for how she holds that political oversight role and how she allows us to be able to do what we need to do as officials. Thank you, Chairperson.
Thank you very much, Minister and Dr. Cloutier. On that note, I would like to reciprocate and thank you, Minister, thank you, Dr. Kluti, and all the officials. I won't be coming back after the 29th. For me, it's been an absolute honor and a privilege. And I admire the way you're conducting yourselves and carrying this department. I wish we could emulate it throughout this country. I know that in the health space, this province is in the best possible of hands. And I really and truly appreciate that. And I take it to heart. And I blow my trumpet wherever I go, exalting the health and wellness department in the Western Cape province. So to one and all of you, thank you on the department side, but also on the side of the officials supporting us, Namonde and Ben and all the officials here supporting us. It's been an eye-opener to me how easy it can actually be done, you know, and how well it's done. So once again, to all of you, to all of the members, thank you, members, for your contribution. Yeah, we'll have another opportunity to say goodbye, hopefully with something liquid in our hands. But thank you very much to all the members as well for the support and the understanding and the way you have allowed me to develop and grow in this. Lastly, Minister, I always say, is die vrou wat nie brieke het nie. Absolutely formidable the way in which you have run this department. You're probably tired of hearing it from me. I still don't know how you put what you do into 24 hours. That's why I say you don't have breaks. And I can only say that I admire you. And I hope that this province and this country will, for many, many years to come, have the benefit of making your contribution felt wherever you go. Thank you so much. With that, ladies and gentlemen, members of the public, thank you for attending. Thank you, Ms. Lake. If you're still with us, I'm going to politely ask you to be excused. Oof. There's at least two matters that she wants to do resolutions on. If you still wish to do so, member, if you could please raise that with us. Would we say a progress report?
Secondly, Chair, can we get in writing that there are all studies made by the department from compensation on the employees and other related expenditure each year between 2020 and 2024. Actually, up until today. Yeah, I think that's my also.
Thank you, members. Any other resolutions or requests? I wish to remind you that these resolutions will be included in the minutes and not in the report, just for your notification. So we will now proceed to the adoption and the consideration of the committee report on vote 6, health and wellness. And I've been advised to report the adoption notice as follows. The Standing Committee on Health and Wellness, having deliberated on the subject of vote 6, health and wellness, in the schedule of the Western Cape Appropriation Bill, Bill B1 2024, referred to it in accordance with Standing Rule 118, reports that the committee supports or does not support the vote. I need to ask here whether there's anybody who do not support the vote. Member
Yes, Chair, the ANC will use the minority view to not support the vote.
It is so noted, Member Windvogel. In that case, I will read a different version of the committee report then. I read again, the Standing Committee on Health and Wellness, having deliberated. No. Yeah. Sorry. The report of the Standing Committee on Health and Wellness on vote 6, health and wellness, in the schedule of the Western Cape Appropriation Bill, Bill 1 of 2024, dated 12th of March 2024, as follows. The Standing Committee on Health and Wellness, having deliberated on the subject of the vote, health and wellness, vote 6, my apologies, health and wellness, in the schedule to the Western Cape Appropriation Bill B1 2024, referred to it in accordance with Standing Rule 118, reports the committee supports the vote. The minority view, in terms of Standing Rule 90, the African National Congress expressed their minority view not to support the vote. Since the ANC is the only party with this minority view, in terms of Standing Rule 90, the African National Congress has expressed its minority view to not support the vote. The committee supports the vote with the minority view of the ANC. And then all with the minority view of the ANC. Thank you. So done. Member Fry.
Chair, I move to adopt the report.
Thank you. A seconder?
I'm second, Chair.
Thank you, Member Poole. Members, once again, I've done my thank yous. Member Fry.
Chair, if I may just say thank you to you. You came in at the short end of the term, but you've led us with aplomb. And I think that I want to say thank you to you and to Nomonde, Mr. Chamtse, for your expert leadership and your wisdom, your weisheit. I will not call you but but thank you for your guidance. Thank you, Chair.
Thank you, Member Fry. Much appreciated. Members, with that, this meeting is adjourned. Thank you.